Hi everyone, what's up? So this is actually being re-recorded. It's currently 2025, so it is not May 5th from 4 to 7 p.m., but there's an issue with the recording of this, so I've been meaning to record this one again. So I actually think this is a good one that now that I've finished my PhD, I've done my third year of medical school. So this is a very clinical lecture. So I think it can be helpful that I finished my well, at least my third year clinical rotation. So I can kind of give those little pearls in there. But I'm going to keep it as relevant to first and second year material as needed. The PowerPoint's the same. It's just kind of going to be my new take on it. Okay, so I call this everything else. So for those that are new here, this is specifically things that are covered on the syllabus for my medical school for the immunology block, which is what these were kind of created for. But there's a lot of good stuff in here. So we're covering lupus, rheumatoid arthritis, some other brief autoimmune diseases, some micro, some cancer, some pharmacology, and then a lot of the imaging, diagnostic testing, and procedures. And it'll all be highlighted. Then we're going to finish with questions, of course. All right, so we're going to start with lupus, or it's also known as SLE or systemic lupus erythematosus. Something that I did want to say before we jumped into the autoimmune diseases. So my disclaimer is for autoimmune diseases, it's kind of like allergies. There's a speculated mechanism of action. There's really no known cause of autoimmunity, but the general accepted theory is that we have a genetically susceptible person and then there's some sort of environmental trigger. This could be a viral infection. This could be a toxin in the environment. Something environmentally triggers this genetically susceptible person to now lose tolerance of B and T cells, which we covered in those lectures. And this is how you get autoimmunity. So for lupus, this is aka SLE, this is aka lupus. This is autoimmune disease. Basically, in lupus, what happens is you're making autoantibodies against your own DNA. So that's kind of the trigger with lupus. This is common in young premenopausal African American females. And I've said this before, for exams, you do kind of want to look at these kind of terms in the vignette because they help you. So another classic example is sarcoidosis, not something we've talked about here, but if you see a young premenopausal African American female, I would think lupus, I would think sarcoid, just in terms of vignettes, not for like actual, clinical medicine in life. Lupus specifically is both a type 2 and a type 3 hypersensitivity reaction. It's more so a type 3, but we're going to review those. So basically what happens is you can kind of think of this as this is like one of your epithelial cells. Here's the DNA inside the nucleus. Some event happens. So here's your environmental trigger in a genetically susceptible person. So let's say this person is HLA-DR3 or HLA-DR2, from that long list in first aid of all the HLA markers associated with the autoimmune diseases. Or it could be, and this trigger could be viral infection, it could be UV light, something like that. This is going to damage the cell, and then your DNA can seep out. From here, an antigen presenting cell will now recognize this DNA as foreign. So it's kind of being looked at as a PAMP. And again, we don't know why this happens. We don't know why in some people, the antigen presenting cells recognize their DNA as foreign. But regardless, then you make an immune reaction against your own DNA. So for type 2 hypersensitivity reactions, remember this is like the antibodies your body makes will attack stationary DNA, right? So that's the type 2 portion of it. But for lupus, I want you guys to think about this as a type 3. This is kind of what causes all the symptoms that you see in lupus. There is a type 2 component, but it's way more type 3. So basically, you make these antigen antibody complexes. So here's your DNA, it's acting as an antigen, right? And then here's your antibodies, the autoantibodies. Now, this whole thing is going to now go and deposit. So it's going to deposit in the skin, it's going to go deposit in joints. This is kind of why you get those systemic symptoms with lupus. Diagnostics wise, you do want to look for that malar rash. A lot of the times they won't say it's a malar rash. They'll say that there's a rash on the cheeks that spares the nasolabial folds. So nasolabial, so as you see here, it's spared in this patient. So right where the nose kind of meets the cheek, those folds are spared in lupus. So that's usually something you can look out for in a vignette. They'll just say, it covers the bridge of the nose, the cheeks, but it spares the nasolabial folds. You'll see joint pain. Again, that's those immune complexes depositing. You'll see Raynaud's phenomena. We'll talk a little bit more about Raynaud's phenomena, but this is super non-specific. This is not associated. Raynaud's itself can just be a primary disorder. Like you can have primary Raynaud's, where that's like the only thing you have. But a lot of the times when you see Raynaud's in vignettes, just something I've noticed, it's usually tacked on to some sort of other autoimmune disease. So again, it's usually present in vignettes in people with autoimmune diseases. I think I can't, I do, actually, let me try to look. I don't remember. If I don't go over Raynaud's in more detail, the thing you're looking for in a vignette is a color change. It's like from red to white to blue. So they'll talk about that distinct color change and then back to normal. That's Raynaud's, okay? So it's like a distinct color change versus like a vasospasm or something like a smoker gets like the thrombophlebitis, like thrombo obliterans thing in the arteries. So that's like what you're looking for in a Raynaud's vignette. Other things you can see serositis, so the pleura can get inflamed, the pericardium can get inflamed. I've seen questions with lupus with cerebritis, so like the brain becomes inflamed, like the coverings of the brain can become inflamed, not the meninges, but the actual brain becomes inflamed. So you can see like kind of those symptoms. Then late stage lupus, you can see kidney disease, and this is one of the nephritic nephrotic syndromes. There's a video on that where I talk about lupus can present as so many different types of nephritics and nephrotic syndrome. So that's all covered in that nephritic nephrotic lecture. Diagnostic. So what are you going to look for? You want to do lab tests for autoreactivity. Everyone that has lupus will get an ANA. So this is the most sensitive test. So I don't think I've ever talked about sensitivity versus specificity, but a sensitive test is basically like you want it to pick, like if a test is like very, very sensitive, you want it to pick up as much as possible. Like you really want it to pick it up, like a positive result. So this opens the door for having a lot of false positives, right? If you're just kind of letting it be like, well, I'd rather get more than less kind of thing. Those are sensitive tests. Specific tests are like, no, I want to make sure it's specifically what we're looking for, not just like picking up on everything. So sensitive tests are good to rule in, and then specific tests are good to rule out. So usually if you have a positive sensitive test, you can't say like, oh yeah, that's the disease. But if you have a positive specific test, then you're a higher likelihood of like, oh yeah, that's the disease. So with lupus, you usually always start with an ANA, so an anti-nuclear antibody, right? Makes sense. You're making antibodies against DNA. So it's kind of like anti-nuclear, where is DNA? It's in the nucleus. So we kind of want to make sure that antibody exists. This is very sensitive, but again, it's not diagnostic. It's not specific for lupus because you can have ANA. People just like walking around can just have positive ANAs just for absolutely no reason. So keep that in mind. You do want to see a positive, like if it's a vignette and the ANA is negative, it's probably not lupus. Okay. So this is a very sensitive test. It's going to pick up lupus if the patient has it, but then you want to confirm it always. So what you want to do, there's two other specific ones for your level for like M1, M2 that you can focus on. So we have the anti-double strand DNA, so dsDNA. This is the most specific test for lupus. It's also, I've seen questions where it's also the most specific test for lupus nephritis. So if it's like you want to see if the patient has kidney disease from lupus, order a dsDNA versus any of the other types of autoantibodies. Anti-Smith antibody, this is also another one that you can see for lupus patients. It's also another specific one, just wanted to put it out there. Other things that you see with lupus, you have inflammation. So think your markers of inflammation. Think of your pyrogens, right? Yeah, like things that trigger a fever. So IL-1, TNF alpha, these will all be increased in lupus because there's tons of inflammation. Lastly, you can look at a CH50. So we have talked about the CH50 test. This is back in the complement lecture. So remember that the complement system, it's kind of like the coagulation cascade, which I know we haven't talked about here, but there are lectures on the coagulation cascade in the HEMONC playlist. But with complement, it's like a series of zymogens in a way. So if you're going to actually be utilizing complement, you're actually going to see decreased levels of C3 and C4. Because again, if you're using up, you're moving through the pathway, you're using up all of these things. Okay, so C3, C4 should actually be decreased in someone with tons and tons and tons of inflammation, someone like lupus. Raynaud's. Okay, I do talk about Raynaud's. So Raynaud's, again, very non-specific. It's tons of autoimmune diseases. It can be primary. Like you can actually answer the question and be like, no, this is primary Raynaud's if there's no other symptoms of autoimmune diseases. Usually this gets triggered in the cold weather. So you'll see that in a vignette. And it is a type of vasospasm. But again, it's kind of like a vasospasm triggered by cold weather, but there is this autoimmune component. But what you're going to look for, and this is kind of what I was alluding to when I was talking about this earlier, is you're looking for that color change, like the specific color change, which they will mention in a vignette. So it'll go from white to blue to red, and then back to normal. That is Raynaud's. Okay. All right. Okay. So next is rheumatoid arthritis, another common autoimmune disease. All right, so rheumatoid arthritis is more common in females, like most autoimmune diseases are. There is a later age of onset than lupus, so you usually see this like 40s to 50s. Lupus, you tend to see like 20s to 40s, I've seen in vignettes. This one's a little bit later. Not saying that you can't overlap, but this autoimmune disease attacks the synovium of the joint, so specifically like where the synovium is. So if we kind of zoom in on this joint, you can see like the synovial fluid within here. This is kind of where the autoantibodies like to attack in rheumatoid arthritis. Something to look for is this is a symmetric arthritis. So a lot of the times they'll put this with a lot of the types of what are they called? Like inflammatory arthritises or seronegative arthritises, like when they're just, comparing and contrasting these. So what you're going to look for, which will really help you with rheumatoid, is that this is symmetric. So you're going to see it in both of your hands, not just one hand or not just like one part of the body. So I didn't mention this earlier with lupus, but with lupus, the joint pain that you see, you tend to see it in the bigger joints. So you tend to get and it's usually unilateral, it's not symmetric. Not saying that it can, especially if they want to be really tricky, but usually in vignettes, it's going to be like, for lupus, it's going to be like one joint, usually a bigger joint. So the knee. Rheumatoid arthritis, it's usually going to be symmetric. I have seen questions where it's not symmetric, but for purposes of M1, M2, it's going to be symmetric and it's going to be in like the smaller joints of the body. So usually it's always the hands. Okay, same thing here, tons and tons of inflammation. So you'll see I have elevated IL-6 and elevated TNF alpha. Okay, so if we kind of think of like the knee, I gave a knee for an example just to highlight the synovial fluid, but if we have like a knee joint, for example, so you see the massive amount of synovial fluid, this is what lines the joint space is comprised of the synovial membrane and then all the synovial fluid in there. So now again, we have some event that happens in a genetically susceptible person. So with rheumatoid, this would be someone that's like HLA-DR4 positive. You get this autoimmune attack on synovial joints in a symmetric fashion. So why is this considered a type 3 hypersensitivity reaction? It kind of seems type 2 to me, right? It seems like we have like a stable joint and then we're getting the autoantibodies that are going there. The reason that you're getting it's a type 3 hypersensitivity reaction is you're making those anti-synovium IgG antibodies, but then what you're noticing here is that you actually make this so think back to the antibody lecture. So we have an IgM, remember that's a pentamer. So that's in red. We have an IgM antibody. And then notice the FAB portion of our IgM antibody is binding to the FC portion of this anti-synovium IgG antibody, right? So it's kind of like remember, these are still going to be specific for the synovium fluid. That's the FAB portion is against the synovium fluid. So these are going to the synovium fluid. But we have this pentamer, this IgM that recognizes the FC portion of these anti-synovium IgGs. So this whole thing is technically what's depositing in the synovium. So you can imagine this is causing tons of inflammation. That's why these people have really, really intense pain, especially in their hands. I don't know if you've ever seen like someone with rheumatoid arthritis, but their hands are all completely distorted, and it's because there's so much inflammation occurring at these joints. Okay. And we'll talk about this. This is a diagnostic test for rheumatoid arthritis. So another thing they like to do, especially first and second years, they like to ask the anatomy about this. So they'll tie in some anatomy here. So like I said, this tends to attack the smaller joints of the body, so your hands. So with the finger synovial joints, something for rheumatoid that is never not going to be mentioned in a vignette is that the DIPs are always spared. Always, always, always. I really like this picture. I think that this helps way more than you think it should probably, but it's like where in the hands out of the three joints in the hand. So we have the MCPs, which are like basically your knuckles or your MCPs. Then you have your PIPs, which are your proximal joints, and then your DIPs, which are your distal joints, right? So remember, proximal is going to be closer to the body, distal is going to be from the trunk of the body, and then distal is going to be further from the trunk of the body. So something that's interesting here is that rheumatoid always spares the DIPs, always, always, always. So you can see here, here's your RA for the MCPs, here's your RA for the PIPs, but there's no RA for the DIPs. And again, like I said, this will be really helpful for when you're learning all of these other types of arthropathies and stuff when you move through your studying. Okay. And then I wanted to show this is kind of like what you can expect to see. So you can see here that the MCPs are really messed up here, and then the PIPs don't look so bad here, but the DIPs are always spared. So these should not ever have any sort of deformity in an RA patient, at least in vignettes. All right, other things to look forward or to look to in a vignette. Look for a mention of morning stiffness. So I didn't put the buzzword B here because this is technically not a buzzword. This is like just true of all like inflammatory arthropathies. But what you want to see, what you want to look for in a vignette is a woman that's going to wake up and then she finds her joints very stiff. So she wakes up, joints are super stiff, but then she gets out of bed, she moves around, and then she goes about her day, her joint stiffness improves. Okay? So that's kind of like the classic vignette for an RA patient. And the primary reason here is that rheumatoid arthritis is primarily due to inflammation. So you're moving around, you're moving your joints, you're basically breaking up that inflammation. And that's kind of why you get improvement as the day goes on. This differs from something like osteoarthritis, where that's like just destruction of the joint, usually due to age or like obesity. And that's like, they get worse at the end of the day because you're just crushing that joint throughout the day. This improves and is actually improves throughout the day. Okay, because you're just, what's causing the pain is the inflammation, so you're breaking up that inflammation by moving around. Sometimes you can also see these rheumatoid nodules. So rheumatoid nodules, a lot of the times you'll see them like on the elbow. You can see them on the hand. I've seen rheumatoid nodules get asked and like think about anything that has like a place that it can like sit on a surface. Usually it's going to be by the elbow joint on the back. Okay, so you can see rheumatoid nodules there. But this is again just massive inflammatory response causing nodules. Again, this is sometimes seen, especially in vignettes, but usually you can figure out the answer based on everything else that they give you. All right. Diagnostics, rheumatoid factor. So rheumatoid factor is the more sensitive test. And I put believe it or not here because literally the name has rheumatoid in the name. But rheumatoid factor is actually it's actually can be present in other autoimmune diseases. I've actually seen so many people get got with rheumatoid factor because the test writers are trying to be cheeky and they are writing a lupus question and then they throw in, oh, there's an IgM against an IgG antibody. And people are like, oh my God, rheumatoid factor, this is RA. No, rheumatoid factor can be present in other autoimmune diseases. So this is more sensitive. This is like the ANA for rheumatoid arthritis. It's sensitive for it. They also like to ask, especially M1, M2, what rheumatoid factor is. So again, rheumatoid factor, we talked about it already. It is, remember, we have these IgG antibodies that are against the synovium. Rheumatoid factor is an IgM antibody against the IgG of those anti-synovial fluid antibodies. Okay, so that is rheumatoid factor. It's an IgM specific against an IgG. Okay, and the FC portion of it. Cool. So, like I said, this can be present in a ton of other autoimmune diseases. Don't see rheumatoid factor and be like, oh, it's rheumatoid. All right. What's more specific for rheumatoid is called anti-citrulline antibody. This is going to be the answer on the test. This is how you diagnose lupus. So this is more specific. So if you get a positive anti-citrulline antibody, then you're like, okay, patient has rheumatoid. I've also seen this asked on exams as anti-CCP. So just something else to keep an eye out for. Okay, so anti-citrulline or anti-CCP, that's the one that you want to look for rheumatoid arthritis. And for whatever reason, so citrulline specifically, just to kind of explain what this is, it's an amino acid incorporated into proteins when there's inflammation. And for whatever reason, it happens the most when you have rheumatoid arthritis inflammation. Okay, so look for anti-citrulline, look for anti-CCP. Other things you can see is elevated, like a SED rate, elevated C-reactive protein. These are absolutely not specific for rheumatoid, but these are acute phase reactants, so they're going to be elevated when you have like tons of inflammation going on. All right. Okay. So next is micro. So I want to talk about how microbes evade our immune system. So RNA viruses, they point mutate like crazy. So RNA, as you know, it's less stable than DNA. It's not, there's no really proofreading of RNA. So you get a lot of point mutations that happen in RNA. Sometimes those point mutations give the virus a survival benefit, and then it stays into, it's basically now it's like staying in that virus's like life. Okay. Um, So, for example, and I have pictures to kind of show it, but for example, COVID-19 is an RNA virus. It point mutates. That's why I think like back when COVID was happening, when there would be like not the different strains, but when there was like different variants. So it's like, oh, this variant's really crazy. This variant's not as bad, blah, blah, blah. Those variants are all point mutations. It's not changing the strain. It's just changing, you're getting a variant of the same strain. Those are point mutations. So COVID-19 is an RNA virus, so all coronaviruses are. Influenza A, HIV, these are RNA viruses. So again, our RNA itself is less stable than DNA, and RNA polymerase does not proofread. DNA polymerase does. So you don't really see these point mutations as much with DNA viruses. All of these point mutations allow the RNA viruses, like I said, sometimes to evade our immune system. It's like it gives it a survival benefit accidentally. A lot of the times it's accidental, but like the virus is like, whatever, I'm better at living now in a human. So that virus proliferates, and that kind of survival of the fittest, right? So this leads to something called antigenic drift. So antigenic drift, this is drifting. How I want you to think about antigenic drift, because there's drift and shift. So drift, I want you to think of like drifting away from a particular antigen over time. These are your variants of your RNA viruses. So if we kind of like look at it with these diagrams I drew. So let's say this is a flu virus, and this flu virus and this is not obviously a real flu virus. Flu viruses have like 8 genomes. I'm just drawing one. This is just for simplicity. But this is a flu virus. Here are white spikes on the surface of the flu virus on its envelope, okay? So think of these as the spike proteins as the white sheet from the ghost analogy. Oh yes, I remember that. I remember that analogy. I forget which lecture that one's in, but this is from a previous lecture. Then you're gonna get these mutations, and then one of the mutations just so happens that now we have red spike proteins instead of white ones. So think of these spike proteins as the red sheet from the ghost analogy in that previous lecture. So now this flu virus has red spikes. So this is a variant of the white spikes. It's not like we made a totally new virus. This is just the same virus. Look, the DNA is the same. Everything's the same. We just have a different now antigen on the surface. So this is an antigenic drift. You're drifting away. And again, this is totally accidental. It's just due to mutations, and pretty much only RNA viruses can do this. This is also why we need the flu shot every year. This is also why it's suggested to get the COVID shot every year, so you can kind of stay on top of these new variants because of the new mutations that are happening. So it's just kind of trying to get you. I know we've talked in the past about like the original antigenic sin. That's kind of what they're trying to do with the coronavirus vaccine, like why you need one every year. But again, this is a new virus, so we don't really have we don't really have a way to track that. But the flu shot, we've been tracking that forever. So we know that it works, and we know that the more antigens you see, the better protected you'll be against any sort of new flu virus mutation that happens in the future. Okay. So this is the reason. If they ask you, what is the reason why we need a flu shot every single year, or like a COVID shot every single year, if they want to make it more relevant, it's because of antigenic drift. These are RNA viruses. You get these point mutations that basically drift away from this particular antigen very slowly over time. Like it doesn't just happen from white to red. This is like a slow process. Maybe like now this turns into a box, and then this turns red, and eventually this will turn red. So it's these little point mutations. And whatever survives, it's because we can't see it. Like the immune system can't see it. Antigenic shift is you're making a totally new virus. So this is kind of like COVID happened, like how COVID-19 specifically happened. This is also like how swine flu happened. Like this is how all those epidemics and pandemics that you see is due to shift. So basically this is like, it's not slowly over time. This is shifting to a totally new virus all at once. So this is very sudden. So what can happen is basically we have like a flu that has white spikes, right? And then we have a flu with red spikes. So this is the variant of this one. And they go and infect the same host. So let's say like a bat, or it can also be like some sort of pig, right? Swine flu. So it can be a pig. It goes and it infects at the same time a host. And then once it's in the host, you can get recombination. And recombination is basically because these are two of the same viruses. They're just kind of variants of each other. So their genomes are recognized by each other. But now you're making a new virus that our immune system has never seen. Because like think about all the possibilities of these two interacting with the RNA, with their genomes. So this is now a totally new species, never seen before. Our immune system has never ever recognized blue triangle spikes. It's like, what the heck is this thing? And this is why everyone got sick from COVID-19, because this is exactly what happened with COVID-19. Okay, so shift versus drift. So again, here's kind of what we just talked about. Here's shift. Here's the last slide. So we have virus A, we have virus B. You get intermixing, and these are probably two flu viruses because there's 8 genomes. It seems, let's see, 1, 2, 3, 4, 5, 6, 7, 8. Yeah. So this is 8 genomes. Here's another flu virus with it's 8 genomes. So this is the same virus. So that's a big thing with the shift is a lot of the times it has to be the same virus. It's just like 2 variants of the virus. I know it's kind of confusing with virus A, virus B. Not saying this can't happen, but a lot of the times it's the same virus. It's just like different variants of the virus because that's where you're gonna have the most success with recombination. So you get intermixing of the genome, and then you get a totally new virus. So I like this because it shows like, oh, here's 4 reds and then 4 blues. So that leads to like a blue spike protein here and a purple one here, like just like a crazy mix of things that our immune system's never seen. So again, shift is when you get 2 different viruses that infect the same host cell, and then you get a totally new virus never seen before. This is responsible for your pandemics: coronavirus, swine flu, the 1918 flu, that one, the Spanish flu. These are all your pandemics. This is exactly what happened for all of those. We just weren't, the immune system just wasn't equipped for it, and then so many people got sick all at once. Drift, again, this is slow. This is just point mutations over time. So it's like we have virus A, and then over time, since it's an RNA virus, no proofreading, just random mutations. But virus, then it turns into virus B, which is, again, kind of confusing. This is just a variant of virus A. But what you'll notice is like it's still kind of similar. So we still have like our orange little circle spikes, but now instead of having a purple triangle, we have like a purple square. And for whatever reason, when that mutation happened, which is here shown here in the red, this is conferring now a survival benefit. Maybe our immune system doesn't recognize the purple squares as well as the purple triangles. So when it sees this, more people get sick. So it stays in the environment more. So again, these are your drifts. So this is your antigenic drift, point mutations. Slowly over time, you get new variants. Again, this is really common with RNA viruses. You can pretty much only see this with RNA viruses because there's no proofreading of RNA polymerase. Again, this is kind of why we get the flu shot every year, as well as these little epidemics. So I know I kind of said epidemic with shift, but remember, an epidemic is just like if there's a flu outbreak one year, that's an epidemic. It's a flu. It's like I think an epidemic. Okay, so it's like kind of like an outbreak of a particular variant. And it's really just because not as many people are exposed to that variant's antigens compared to years past. Okay. Next is strep pneumo. So strep pneumo, sorry. So strep pneumo, how does strep pneumo evade the immune system is that it has a capsule. So it's encapsulated, and there's over 90 different capsule serotypes, so lots of them. So if we have strep pneumo here in the dark blue, here's a capsule, it's a light blue capsule. Here's another capsule, light orange. Here's another capsule, yellow. So you can see there's a bunch of different variants. So like maybe when you got your vaccine against strep pneumo, you got the one against this purple capsule, and then maybe you got one when you got your booster against this one. But the reason you can get pneumonia, or like if you're younger, you can get like the upper respiratory tract infections with strep pneumo, is because there's so many different serotypes. So if that one just happens to be on the surface that infects you and you don't have immunity to it, you can get infected. How do capsules work? So capsules will prevent opsonization. So we've talked about opsonization in previous lectures, but opsonization is basically what allows a bacteria to be tagged by the immune system for it to be removed, usually by the spleen. So since this capsule prevents opsonization, that's one huge way that it evades the immune system, is it basically you can't see the organism, you can't see the antigens. So I like this picture. I'm going to jump down. So I really like this picture a lot because you can see strep pneumos here in the red, and then its antigen is in like the orange, the little orange dots. These are its like antigens that we recognize, that like your immune system can recognize. But here's a capsule, and capsules are mostly made of polysaccharides. Polysaccharides are really hard to make antibodies against, and really hard to make T cells against, as we've talked about in the past, because it's not protein. So even if we do make antibodies against a capsule, it's really hard to keep immunity to that capsule. It kind of wanes over time because, again, it's mostly polysaccharides. So if you can see in this picture, this capsule is pretty much hiding the antigens of the strep pneumo. Okay, so again, these are your PAMPs that are located on the surface. Here's the receptor for the PAMP, but our immune system can't see it because the capsule's there. Another thing that it does to help evade the immune system are those serotypes that we've talked about. So again, it's kind of whatever it wants to, whichever strain you're infected with is going to be based on that serotype. So again, it allows immune evasion because honestly, we don't have ways to prevent every single capsule in a vaccine or just from natural immunity. Okay, so here's a picture kind of showing what we just talked about. There's many serotypes of strep pneumo, which differ in their capsular polysaccharides. Like I said, capsules are mostly made of polysaccharides. So this strep pneumo capsule can have the yellow triangles, this one can have orange squares, this one can have blue circles, so forth, so on, right? So if you have a person infected with one serotype of strep pneumo, fine, you'll make antibodies against it, which is great, fine, we'll clear it. But these antibodies can't prevent infection of a second serotype, like this blue one, because it's just specifically against the yellow ones. So like I said, this is kind of why over time you can keep getting pneumonia over and over and over again, or like an upper respiratory tract infection, because even though you're making antibodies against all, there's just so many. All right, T. brucei. So how T. brucei, so I think it's Trypanosoma brucei, how this one's classic for like a classic example of immune evasion. So what this one does, it's called antigenic variation. This one's actually really cool. I actually this is like one of my favorite bacteria in terms of like immune evasion. Bacteria are so smart. Like they're so smart. So what this one does is T. brucei periodically will just switch its VSG. VSG is what is basically its antigen on its surface. So if we look at this picture, here's like a T. brucei with the green VSG. This is like the sign for transcription, right? So it's transcribing this green VSG, and then you're making the green proteins after translation, and that's what's on the surface. Then let's say it turns on blue and yellow VSGs, and that's what goes on the surface. Or maybe it turns on the red ones, or any combination of this. The trick with T. brucei is it can do this literally whenever it wants. It can be green, and then it's like, oh, I'm just going to do blue and yellow. Oh, just kidding, I'm going to do red. So like, let's say you make antibodies against the green. Before it's even able to go and attack it, it's like, nah, I'm going to change. I'm actually going to go to red. I actually think I'm going to go to red. So it can do this literally whenever it wants. And I think this was supposed to be a link. I actually tried to click it before I did this. I don't have a link to this, so I don't know what this is. But I think what it was it was like one of those memes. It was like a meme video, and it was like, this is how T. brucei evades the immune system. And it was just like this guy just like running down the street being chased by cops or something. And he had like a red hat on, then he like takes it off, and then there's a blue hat under, and then he takes it off and it's a green hat, like something like that. That's kind of what T. brucei does. It's like, oh no, the immune system's on my trail. And then it like just switches. It just like takes off the hat. It's like, oh, maybe they won't recognize me now. Yeah. So that's what T. brucei does. Okay, yeah. So I don't know why I put this like so like small on the bottom of this slide, but oh yes, I remember. So Neisseria gonorrhea. So nice. I don't have like its own slide dedicated to this because I don't think this was on like the syllabus. But something that's interesting is, you know how we have like a meningitis vaccine. You guys probably have gotten it before you went to college. It's usually when it's indicated for people to get it. So meningitis has a capsule. And it doesn't really do what strep pneumo does, where it changes, like it kind of has like all these variants of the capsule. But it does have a capsule that you can get vaccinated against and then protect yourself from meningitis. So what about Neisseria gonorrhea? Neisseria gonorrhea doesn't have a capsule, but Neisseria gonorrhea can do this. Neisseria gonorrhea can do antigenic variation. So it can kind of do this. This is, again, why we have a vaccine for meningitis because of the capsule, but we do not have a vaccine for gonorrhea. The reason why is, can you imagine targeting an antigen that just like changes whenever it feels like changing? Like there's no way. And like, again, like and actually, if you made a vaccine against, like, let's say you made a vaccine against all four of these, it would kind of like, again, survival of the fittest. It would kind of like evolution would make it so there's a new VSG that's being made. So it's like you'd have to like make a vaccine that could cover all potential, VSG antigens, whatever it would be called in gonorrhea. And it's just not feasible. You can't do that. So that's why we don't have a vaccine against gonorrhea, but we do have one against meningitis. And obviously there's no vaccine against T. brucei for the same reason. HIV. So HIV is my favorite virus. I love HIV because it's so smart. It's literally like one of the smartest viruses in the world. So I'm not going to go into too much detail about HIV. I can talk about HIV at at a later time in the future. Actually, people have said that they wish I do have an HIV lecture. So maybe I will do one on HIV and just talk just nerd out about it. But what I want to talk about is just very briefly, how HIV evades the immune system. So specifically what HIV does to evade the immune system is it establishes latency. So HIV, it's an RNA virus, but it's a retrovirus. So it reverse transcribes the RNA into DNA, and then that DNA can basically go implement into our cells. So can integrate technically DNA. I mean, technically, yes, it's RNA because that's what genome it is, but it reverse transcribes its RNA into DNA, and then our DNA, oh my gosh, all right, so we have HIV. Okay. Also, I'm so sorry. My allergies are like horrific, so I keep drinking and everything. I'm so sorry. I'm not usually this allergy-y, but so here's RNA, and HIV is going to enter our cells. It has reverse transcriptase, so it reverse transcribes RNA into DNA. And now this DNA can be integrated into our cells, into the human cell. So now HIV is with you forever. So it's like, this is our DNA in red, and then HIV can implement itself right here. Our body doesn't know the difference. It's like, oh, there's DNA. You know what I mean? So this is the mechanism that HIV can evade us, is that it establishes latency. It basically enters our own DNA and kind of hides out in our own DNA. And then whenever it feels like it can just pop out and just start replicating and make new HIV virions. Okay, usually it's when you're stressed or when your immune system begins to wane in old age. That's how a lot of like these latent viruses do it. So another good example of this is herpes. So, like herpes simplex virus does this too. That's why you tend to get like your cold sores when you're more stressed and stuff like that. It's kind of, or like you get like what's that called? Shingles when you're older in age, because whenever your immune system starts to wane, you have this virus forever because it's established latency. So like HIV does, well, HIV is a little bit more aggressive than that, but HSV and VZV, so like shingles and your herpes viruses, whenever you start to be more stressed or your immune system's a little bit lower, it can pop out and replicate, and then you can get the symptoms of it. Okay, but HIV specifically, it does establish latency, and that is how it hides. So that's kind of the answer here. But it specifically does this in your CD4 positive T cells, so your helper T cells. So here is kind of the whole viral cycle of HIV. I'm not going into this right now, but I just want to kind of show you. Here's it attaches, it enters, it uncoats. Here's your RNA, well, HIV's RNA, and then it's going to get reverse transcribed to DNA, and then DNA itself is going to go and integrate into your own. So this is a CD4 positive T cell. This can also be a macrophage. I have seen questions like for second years where people get really confused because they're like, macrophages. Yeah, so HIV can also affect or infect macrophages. So it's like macrophages, I think dendritic cells, don't quote me on that. But CD4 positive T cells are the main ones that it infects. But it also can do this with macrophages for sure. But regardless, this is just your CD4 positive T cell DNA in blue. Here is your now DNA from HIV, and now it's integrated into the genome. Whenever it wants, literally whenever it feels the need to do it, it can pop out. it can like have it pop out, and then it can get transcribed, translated, and then here you go, you make new HIV virions, and then it can go infect other cells and whatnot. That's all I'm going to say about HIV. We can go into this in way more detail in a future lecture. Super antigens, my favorite. You guys are gonna get so many questions on super antigens. So hopefully this will make sense, okay? So there's two very important super antigens to know at this level. One's from staph, one's from strep. But I wanna talk about what super antigens are first. So a super antigen is a super antigen. No, but it's a really, basically it's like a really good antigen. Like it's just an antigen that's good at like being an antigen. Like, so you get this really crazy, massive immune response from it. So these are toxins that non-specifically cross-link every single T cell's TCR outside of the normal MHC binding groove. So I want to break down what this means, okay? So I want to break this down using this picture. So it will non-specifically, so it doesn't, remember in the whole T cell lecture, we go into how the T cell receptor has to recognize its antigen in a very specific way. So it's like the MHC class 2 has to present it in, you know, the hot dog with the hot dog bun, right? Like it has to present it so specifically to the T cell receptor, and the T cell receptor has to like do this really nice dance of recognizing self and non-self at the same exact time, so it can perfectly recognize this antigen, and then it can kill it if it's foreign, or not do anything if it's your self antigen. So you don't get tolerance. So what happens with super antigens is they're not in the groove. They're not in the binding groove. So this is normal. So picture one, well, on the left side here, this is normally what happens. So we have our T cell. Here's your T cell receptor, alpha beta. Here's MHC class 2 being presented by the MHC. Here's just a regular antigen in yellow. Normally, your T cell receptor is going to recognize this, and then you either make an immune response or you don't. Super antigens, what they do is like, here's, let's say an MHC class 2 is presenting this antigen. Here's your super antigen. It's not in the binding groove. It's kind of like on the outside. It's kind of like on this weird, like I literally think of super antigens exactly how this picture is showing it. But what this is doing is it's cross-linking this T cell to this antigen presenting cell. So it's not letting it leave. Like you're getting like this cross-linking where this T cell is just going to stay activated like forever, which is not good, right? Like this is not good. Usually you want it to like do what it needs to do, go find other cells that it needs to activate, go kind of do the immune system. The super antigen doesn't let it go, basically. So this T cell is just seeing this antigen over and over and over and over again. It's freaking out, and it's releasing tons and tons and tons and tons of cytokines, okay? And another thing that happens, it's really crazy. So one, it's outside of this groove. Two, it does this for every single CD4 positive T cell that it can find. So every helper T cell that it can find. So that's called like polyclonal activation. So it's like all of the T cells it can find. Well, CD4 positive T cells it can find. And two, it does this. No, I think I said everything. No, I think I said it, sorry. So it's like doing this. So one, it's outside of the groove. Two, it's cross-linking, and three, it's like every single CD4 positive T cell it can find. So you get this massive, massive, massive immune response because it never stops, and it's every single CD4 positive T cell. So this, you get massive cytokine release to the point where this is now called cytokine storm. So this is basically like a cytokine storm. People can die from super antigens because of the massive immune response that's happening. Okay, so if we talk about one of them, Staph aureus' super antigen is called toxic shock syndrome toxin 1, so TSST1, and it's a super antigen and it causes toxic shock syndrome. Love when that happens, right? When it like actually names the toxin for what it does. So TSST1 causes toxic shock syndrome. Basically, toxic shock syndrome is anaphylactic shock. And again, shock is in the name, right? So we know we have like a shock presentation here. But basically what's happening, and if we kind of look at this picture, here's like another version of this picture. Here's your T cell receptor at the bottom. This is CD4 positive T cell because we're recognizing, nope, CD4. Because we're recognizing antigen presenting cell, presenting antigen MHC class 2. So again, normally it's going to recognize whatever this red antigen is, and that would be the end of it, and it would go do its immune response. But the super antigen is going to non-specifically kind of bind, and then you're going to get cross-linking. And you get cross-linking, you get this really insane amounts of activation by the T cell. So what are some things that you'll see in a vignette to kind of point you in the way that's what's happening? So you get insane cytokine release. So shock, that leads basically to shock. So I'm going to skip down to your massive drop in blood pressure. That's basically what kills these people is like this. You get tons of vasodilation everywhere because of the cytokines that are being released. You get tons of inflammation, and then that leads to a shock presentation. The other thing too, and I put the little buzzword B because if you see, so if you're like, oh, I don't know if this is anaphylactic shock, I don't know if this is septic shock, like I don't know what type of shock this is, look for this desquamating rash. So this is kind of a little bit more specific for toxic shock, like a superantigen, toxic shock syndrome. Look for like a rash that desquamates. So it can kind of like, it's everywhere. It's like peeling off. Okay. And then this can usually lead to death. And with this, since it's from Staph aureus, is that you can see this in packed wounds and tampon use, which I will explain, I think, on the next slide. So, and again, if they are pointing you to the direction of like toxic shock syndrome, they need to give you some indication that it would be toxic shock syndrome. So they'd have to talk about an instance where Staph aureus would be activated, basically. So look for your packed wounds, look for your tampon use. So to understand, I'm so sorry, guys. So something to understand about Staph aureus is it's a commensal. This means it is normally located in your body. Usually it's in your nose, it's in the skin, it's down in the vagina. It's just like located throughout the body. It's a commensal. It just lives in us, which is okay, But if you pack it in, so you pack it in, let's say in the nose, you pack a wound, you put a tampon in, you're now packing in staph because remember, it's located like everywhere in the skin, in the nose, in the vagina. So if you're packing it in, it thinks it's being attacked. Like it's like, what the heck is this? So if you do this for too prolonged of a time, that's why they say change your tampons every, 6 or so hours. I think it's 6 hours, whatever the recommended thing is that they say. But it's just like, don't leave it in for so long because you can get an increased risk of getting toxic shock syndrome. But I have seen this because I know that vignettes know that people know about tampon use causing toxic shock. So I've seen this a lot more with like nose packings. So someone breaks their nose or someone needs, they have like a posterior, I don't even know, like they have like a nosebleed that won't stop. So they pack it. And then they're like, oh yeah, I just kind of left it there for like a few days. And now they're having this rash and their massive drop of blood pressure. They just feel really sick. They don't look good. Think about toxic shock. I've also seen questions with like a wound packing where it's like on the skin somewhere and you like have like a wound, so you pack it and then you just leave it and you never change that. That can also cause toxic shock. Okay, because it's kind of like Staph aureus is freaking out and it's like, oh my goodness, and then it releases this toxic shock syndrome toxin and that leads to death. So again, look for vignettes describing someone who kept a nasal packing in for multiple days in a row without changing it, or like a tampon in for 12 plus hours, and then they're experiencing like these symptoms of shock. And the whole reason I said the whole 6 hours things earlier, because it's like there really is no time frame. Like I didn't want to give like a specific time frame for like what to look for tampons. They will make it very obvious. What I've seen mostly for like toxic shock syndrome vignettes is like 12 or 24 hours is kind of what I see. It's not going to be like, oh, you're supposed to change it every 6 hours and this is 8 hours. Just, it's kind of going to be a little bit more. I even think they'll make it more aggressive than this. Like I think they would do like 24 hours or like, oh, they didn't even know they had a tampon in and it kind of just stayed and they forgot about it. And now they're having these shock syndromes. Okay. Strep pyogenes can also cause superantigens. So strep pyogenes, its superantigens are called SPEA and SPEC. I forget what it stands for. It's like strep pyogenes something A and then strep pyogenes something C. But regardless, A and C, there's no B. And these, it's also a superantigen, so it's the same pathogenesis of toxic shock syndrome, but it's less commonly seen in prolonged tampon packings or nasal packings. Like you'll usually see this if you have like a strep pyogenes infection. And then now you're having like these symptoms of shock. You can think about this superantigen. Another protein to pay attention to with strep pyogenes, so not its superantigen, is the M protein. So M protein is a virulence factor. Remember virulence factors, these are things that help bacteria with its pathogenesis to be like a virulent organism. The immune system makes antibodies against M protein. So it gets infected with strep pyogenes. This is your group A strep, this is your strep throat. So it gets infected with it, makes antibodies against it. And now we have these antibodies against M protein. The problem is M protein is very similar in structure to the mitral heart valve. very similar for whatever reason. So it's basically like you're making, in some instances, an antibody against your mitral heart valve. This is called molecular mimicry. So molecular mimicry is when your immune system tries to make an antibody against something that mimics something that we have normally. So like your own self. That's molecular mimicry because molecularly it looks very similar. So you can get like cross reactivity basically. So this is kind of what I want to mention here is that even if you clear out strep pyogenes with antibiotics, sometimes the immune system will attack the mitral heart valve because it thinks it's M protein. Okay, so this is how you get rheumatic fever. So rheumatic fever is basically you're attacking your mitral heart valve. This is a type 2 hypersensitivity reaction. Type 2, because it's the mitral valve is a stationary antigen basically, and you're making antibodies against that. So that's type 2 hypersensitivity. So this is actually from the hypersensitivity lecture. We did talk about this here. Again, this doesn't happen in everyone that gets group A strep infections. It doesn't. You also remember this needs to be in people that have these autoreactive B and T cells for whatever reason. In those people, they have a loss of their peripheral tolerance. Maybe there's a genetic component, who knows, with these autoimmune things. But what I want to throw out here is you don't have to really know the specifics of this, but I just kind of want to show here is like your oropharynx. So this is like your throat. Here's strep pyogenes. It invades. It comes into like the peripheral blood, right? Here's strep pyogenes being presented. So it's an antigen presenting cell to one of your CD4 positive T cells, and your B cell is going to make antibodies against streptococci. So it's going to make that so you can clear it out. Let's say you completely clear it out. You feel so much better. You get antibiotics. You feel great. But you still made, sometimes not all, you do. You make these antibodies against M protein. M protein, again, for whatever reason, in these patients, you can get molecular mimicry and you can get rheumatic heart disease. So several heart tissue proteins in the myocardium and valve are recognized by autoreactive antibodies and T cells. And this is the key, autoreactive. So again, you need that loss of peripheral tolerance. This doesn't happen in everyone that gets strep throat. Oh my gosh, I've had strep throat so many times when I was younger. I don't have rheumatic heart disease, right? So again, you need to have these, for whatever reason, in some people, they have a loss of their peripheral tolerance, and that's who's going to be susceptible to this. But this is called molecular mimicry. So strep pyogenes is like known for this. And then there's another one we'll talk about that is known for this right here. So Guillain-Barré. So Guillain-Barré is another classic example of molecular mimicry. So usually it's going to be following a GI infection. So usually it's like a GI, so it's like a non-specific diarrheal illness with Campylobacter jejuni. Campylobacter loves to do this for whatever reason. So Campylobacter jejuni, or following just a non-specific upper respiratory tract infection. And again, like I said, in vignettes, they won't say patient has Campylobacter jejuni. They'll say like not just like diarrhea for like a week or two, like a week. Like they had diarrhea for a week, no blood. It was just kind of like whatever, just like this diarrheal illness. Or they've been sick. They like 2 weeks ago, they had like a sore throat, cough, congestion, stuff like that. So you can tell it's like a viral tract infection. And then like 2 weeks later after this infection, they have this ascending peripheral neuropathy post-infection. So it's going to start from the legs and then work its way up. And it's going to be symmetric. So, and it's a peripheral neuropathy. So that's kind of like this meme here after a respiratory infection. You're like, oh, Guillain-Barré, but also think about Campylobacter jejuni. Campylobacter jejuni is the one they usually ask about because we have an actual like organism in mind. And so what happens here is classically molecular mimicry. So this is like rheumatic fever. This doesn't happen in all patients, just those that have lost the peripheral tolerance for whatever reason. So again, you don't have to know the specifics of this picture, but here's Campylobacter, you get your immune response, great. You make your antibodies against it. But again, you get cross-reactive antibodies in some patients for whatever reason. These cross-reactive antibodies can now attack your peripheral nerves. So for whatever they like have cross-reactivity with like the lipid A that can be located in the outer membrane of Campylobacter, and it looks very similar to ceramide, which is like a sphingolipid located in your myelin of your peripheral nerves. So like sphingomyelin, right? So that's ceramide. So you can get destruction of your peripheral nerves, and that's how you can get Guillain-Barré. Usually though, for whatever reason, it starts at the bottom, so like your feet, and then it moves up. And that's kind of what you want to look for in vignettes is it's like it's ascending, but it's symmetric, okay, on both sides. And usually Guillain-Barré goes away on its own, usually. But you can give like antibody binders to try and like help with it. You can give stuff like that. But if someone does die from Guillain-Barré, how they die is that the ascending infection went all the way up, and it's just ascending, ascending, ascending until it gets to the diaphragm. And then when it gets to the diaphragm, you stop breathing because you have paralysis basically of your diaphragm. Okay. Next is opportunistic infections. So opportunistic infections, these are microbes that shouldn't normally cause disease, but they can in patients with a compromised immune system. So normally, and this is what I highlighted, this is you see in vignettes that you should think of having an opportunistic infection. So patient has cancer, patient has HIV/AIDS, patient just underwent an organ transplant, so they're going to be on tons of immune suppressants. Patients with immunodeficiency, pregnant patients. So pregnant patients are actually immunocompromised. That's why there's certain things you can't eat when you're pregnant. Very young patients, very old patients, or those on long-term steroids. So these are the people in the vignettes that are going to have an opportunistic infection. So again, they have to tell you something, like they have to give you an instance that a patient should have an opportunistic infection. Like it can't just be like a totally healthy, normal 30-year-old now all of a sudden has, I don't know, pneumocystis jirovecii pneumonia. No, like it has to be for some reason they have to be compromised. Oh, but did they tell you that this 30-year-old just got an organ transplant? Okay, so there's got to be an indication that they would have an opportunistic infection. If you have a B cell deficiency, so we talk about immunodeficiencies, which the immunodeficiency lecture I think was the last one, so this was all covered in that. But if you have a B cell deficiency, you tend to get more bacterial infections. So you tend to get infected, or they present with recurrent bacterial infections. T cell deficiencies tend to produce more viral, fungal, parasitic infections. So it's kind of like the idea, I think I've explained this in like the last one, but B cell deficiencies, you really can't make antibodies, and antibodies are kind of like how you attack bacterial infections and get rid of those. T cell deficiencies, you really need T cells to help get rid of like intracellular pathogens. So that's going to be more viral, fungal, parasitic. Fungal, I have seen fungal infections with your B cell deficiencies, but for purposes of opportunistic infections, I group fungal with viral and parasitic. If a patient has decreased T cells, again, we just said this, T cells need to get rid of intracellular pathogens. I want you to think about viral infections, okay? So some of the viral infections to think about is CMV, EBV, VZV. So cytomegalovirus, Epstein-Barr, and varicella zoster, okay? Now what I put here in red, this was an addition. I just did this because I noticed they asked about this a lot, especially for like, I'm step 1 tutoring right now for some of the second years, and they're like, oh, do I have to memorize this? Yes. So what are the CD4 positive T cell counts that if you have HIV or AIDS that you tend to see these opportunistic infections? So for CMV, you tend to see, and again, if you look online, you can find ones for all of these, but this is just the ones that they typically ask about. So that's all I kind of put on here. So if you have a CD4 count less than 50, like in the vignette, and you'll see this with questions that we do at the end, some of the questions, like they give you the CD4 counts. So if you have a CD4 count less than 50, I kind of want you to think about CMV. There's another one, I didn't put it on here. It's like Mycobacterium avium complex. That's another one less than 50. Then Epstein-Barr, BZV. You can also think about more fungi and parasites. Something I want to delineate is like you get local candida infections. Oh my God. Like local candida. So like more, you don't get like systemic candida symptoms, but more local. And you can also see chronic infections with candida. So it's like you have chronic candidiasis and you don't know why. It's like just there forever. I think there's an immunodeficiency. I think I do talk about it, the chronic mucocutaneous candidiasis, the CMC. That's a T cell deficiency issue. For pneumocystis jirovecii pneumonia, so I abbreviate that PJP. I know a lot of people do like PCP or I don't even know, but that's what the PJP is for. It's pneumocystis jirovecii pneumonia. So this, you'll see if you have a CD4 count less than 200, okay? Cryptococcus is another one, and then toxoplasmosis is another one. So toxoplasmosis, you need your CD4 count less than 100. Now, toxoplasmosis was not on this study guide when this PowerPoint was being made, so I don't talk about toxo too much here, but I do talk about toxo with torch infections in one of the reproductive lectures. I talk about toxoplasmosis, but that's a torch infection, that's pregnant women. This is for specifically toxoplasmosis for if you're immunocompromised. So in immunocompromised patients, your CD4 count needs to be less than 100 for you to really be diagnosed with toxoplasmosis, at least in vignettes, not in real life all the time. All right, so let's start with CMV, EBV, VZV. So for CMV, this is cytomegalovirus. The symptoms for CMV are creep, so creep symptoms. So this is colitis, retinitis, esophagitis, encephalitis, and pneumonitis. I think of CMV as basically causing big things. So big colon, big well, not like big, that's kind of more of, yeah, I won't go there, but this likes to infect the big organs, really. So like it likes to infect the colon, it likes to infect the eyes, likes to infect this esophagus. I guess these aren't really big organs. I don't really know, but it does infect kind of like, these are the main ones I see. Colitis, retinitis, esophagitis is what CMV likes to infect. You see CMV infections a lot of the times after like post-transplant patients. That's the number one time I see CMV in vignettes. So look for like a post-transplant patient that now is having like inflammation of the colon or inflammation of the eyes or inflammation of the esophagus, something like that. And then let's say they do like a biopsy of the colon, you'll see linear ulcers, okay? So that's what you'll see with CMV. Okay, you'll see linear ulcers. If you were to look in the retina during someone that has CMV, you'll see cotton wool spots, and that's just an indication that they have retinitis. Biopsy you'll see cells with intranuclear inclusions. A lot of the times they don't tell you they're alloy inclusions, but they'll say like, you know, like intranuclear inclusions, they'll show you a picture, something like this. So here's an owl, here's allies, and then it's supposed to look like, this is like what CMV looks like. Now, this looks very similar to your Reed-Sternberg cells in your Hodgkin's lymphomas, which I do have a lecture on in the heme-onc section. It looks exactly the same. So if you just go off of biopsy, I can't look at this and be like, oh yeah, that's CMV. And then I see another biopsy, I'm like, oh yeah, that's a Reed-Sternberg cell. That's got to be Hodgkin's lymphoma. Doesn't work like that. They look identical, but you have to put the whole picture together. Like, what's the whole picture? Is this an immunocompromised patient that we know about? Like, they're telling us like, oh yeah, they just got a solid organ transplant. Oh yeah, they have HIV, less than 50 CD4 positive T cells. Like, what's kind of going on there to know that it's CMV versus like a Hodgkin's lymphoma Reed-Sternberg cell, okay? Another thing too I've seen in vignettes about CMV is it also causes mono-like symptoms. So it sounds exactly like mono in some instances, like the patient's like, oh my God, I have really big lymph nodes. I have like I have like a posterior cervical lymphadenopathy. I'm just tired. It really sounds like mono, but then you do a monospot and it's negative. So that's another kind of like buzzword for CMV is like monospot negative mono, basically. Okay. EBV, this is Epstein-Barr. This is actually what causes mono. But in compromised patients, so someone with AIDS, it causes oral hairy leukoplakia. Oh my God, oral hairy leukoplakia. Okay. So oral hairy leukoplakia in an AIDS patient is going to kind of look like, so basically what they're going to say is like they're like these white lesions on the lateral tongue, but they're going to be unscrapable. Like you try to scrape them off and they don't come off. That is, they're trying to tell you this is Epstein-Barr. This is not Candida, because remember Candida, you get the the white lesions, but they do scrape off. They're unscrapable. So if you see that, this is Epstein-Barr, okay? Another thing that Epstein-Barr does is it causes infectious mononucleosis. So again, this is your mono symptoms. Now you have a positive monospot test, so you know it's not CMV. And then what does EBV like to do? And this is, they love to ask, everything in this bottom part here is like a very high yield thing that they like to ask about mono. So mono likes to hide. So once you get mono, it stays with you forever and ever and ever, which is so lovely. But it establishes latency within B cells. So there's a few things that I want to say here. So mono hides in B cells, and it does this via the CD21 receptor on the B cells. And how first aid has its mnemonic to remember this is you must be 21 to enter a bar, Epstein-Barr. So you remember it, so it will evade the immune system by establishing latency in B cells using CD21. But then they'll show you a peripheral blood smear like this, and you'll see reactive lymphocytes. And I think I talk about reactive lymphocytes in the peripheral blood smear, like the histology lecture, which I think is number 6, I think, lecture number 6. But regardless, your reactive lymphocytes, remember, they're going to be these really giant cells, like they look like just really giant cells. And then you can see their cytoplasm is kind of indented by red blood cells. That is a reactive lymphocyte. And they'll usually ask, like, what type of cell is this? This is a CD8 positive T cell. I would be very shocked if you did not get this question on boards, on a future test, something like that. They love to ask that because they know people know that mono hides in your B cells. But then when they're like, oh, what type of lymphocyte is this? Is this a B cell or is this a T cell? What's your reactive lymphocyte? Everyone's like, oh, it must be a B cell because that's where mono is hiding. No, reactive lymphocytes are CD8 positive T cells. Okay. All right, and then VZV, this is varicella zoster. This causes chickenpox when you're younger, and then it stays with you forever and ever and ever. And then when you're older, elderly, or you get some sort of immunodeficiency, like you get HIV/AIDS, it can come out. So that, and then it causes shingles. So this will establish latency, and where VZV likes to hide is in the dorsal root ganglion, so the DRGs. So if we look at a spinal cord, oh goodness, I wasn't prepared to talk about spinal cord stuff. Okay, but regardless, these are your dorsal root columns, right? So back here, so this is the back of the spinal cord. And I go into like this, like neuroanatomy stuff, like with the spinal cord and whatnot in one of the neuro sessions. Okay, so then remember we have your dorsal root ganglion, and they bring in sensation from like vibration, positional sense, stuff like that. Wow, that one's so much better than that one. All right, whatever. But where varicella zoster likes to hide is within the dorsal root ganglion. So it likes to hide back here into these like ganglion. All right, so it hides there forever. And then when you become immunocompromised, VZV can wake up from its dormancy in the dorsal root ganglions, and then it starts moving along the nerve root. So what you're looking for is you're looking for like a seatbelt rash is what people call it. So it's like you get this rash that is like, it's like imagine putting on a seatbelt, like it's going to go in like a nice little like synchronized order. Like it looks like it's moving towards the midline, but VZV rashes do not cross the midline. So I think this is a really good example of it. So you can kind of see it here, where it's kind of like you can clearly see a rash, and it's kind of like it comes up and it kind of comes down like this because it's following a dermatomal pattern. And if you TBT to dermatomes, right? So if you look up dermatomes, you know, they kind of swoop up and they kind of swoop in. That's why they call it like a seatbelt rash, because it starts up and then it comes in, but it never crosses midline. So if you have, let's say this picture showed a rash that went across the entire body, that can't be VZV because it sticks to one dermatome. And remember, you have like it's only on one side. Okay. Here's what it looks like. They'll talk about like a vesicular rash. They'll say it looks like vesicles. This is what vesicles look like. Like they look like they could like pop at any second. That's like what a vesicular rash looks like, varicella zoster. All right, oral candidiasis. Like I said, this is local candida infection here. Candida albicans is a type of yeast. So if you see this presentation, this is called thrush or oral thrush. And how this differs from your oral hairy leukoplakia is that this now, if you see this, you can scrape this off. So if you try to scrape it off, it does actually come off. That you're like, okay, this is candida. This is not EBV. Usually this occurs if you're in a immunocompromised patient. You'll see the oral candidiasis, but how you can kind of tell that this is like HIV/AIDS, something like that, is you see esophagitis. So if you see candida esophagitis, so it goes from, it's not just in the mouth, it goes down into the actual esophagus. Now you're like, oh, this is candida esophagitis. That is an AIDS defining illness. What AIDS defining illness means is basically like the only patients that can get it are someone that's like very immunocompromised. It's not just saying like, oh, it's only patients with AIDS. I know it's kind of annoying because it's like AIDS defining. It's not just only people with AIDS, but it's kind of like you have to be very immunocompromised in order to get it, like an AIDS patient is. Okay. What else? I will say too, another thing that you can see oral candidiasis is if you have asthma and you use an inhaled corticosteroid. So if you inhale, like one of your inhalers is a corticosteroid inhaler, and you use that every day, and then you don't use like mouthwash afterwards, after you do it, you can get this as well. You can get oral candidiasis. So that's like another way. It's not really an immunocompromised state. The really immunocompromised state is going to be the esophagitis. But you can also, if you see this in someone and it scrapes off, there is something happening, but it doesn't mean like it's either maybe they're taking an inhaled corticosteroid, maybe they are, they have like some sort of T cell deficiency, something like that. But once it goes into the esophagus, that's like you're at AIDS level immunocompromised. Okay. PJP, so pneumocystis jirovecii pneumonia. So PJP is a fungus. It will cause an asymptomatic pneumonia in an immunocompromised patient. So some things that I've learned about PJP and want to mention now is that it's always bilateral, always, always, always. And you see like these interstitial infiltrates bilaterally. So it's not like with normal pneumonias, you think of like there's like a lobe, like a specific lobe of the pneumonia. A specific lobe of the pneumonia becomes like, not, I'm sorry, you see normally like a, not a lobe, but like a consolidation. This you see bilateral, so it's on both sides, and it's like non-specific, like infiltrative, like it's kind of just like you have these non-specific increased interstitial markings on both sides of the lungs in a chest x-ray. Okay. If they want to talk about, they can also mention, usually not so much with chest x-ray, usually they mention it with a CT scan, but I have seen questions where they do mention it with a chest x-ray. I don't know, I'm not a radiologist, so I don't really know if that's doable. But if you see the ground glass opacities, that can also help you kind of delineate that they're talking about PJP. How you diagnose this is you do methenamine silver. So you'll do methenamine silver stain, and then you look for disc-shaped yeast. This exact photo, I'm shocked. I found the same one online, was on my step. So they basically described this patient. I think they did say that they had HIV. CD4 count has to be less than 200. Remember, for PJP, it's got to be less than 200. So like maybe their CD4 positive T cell count was like 150, 100, whatever. So something like that. And then they were like, oh, they did like this is kind of what the chest x-ray looked like. And then this is what the methenamine silver stain showed. And there's like, these are disc-shaped yeast. So it kind of looks like you're throwing a disc, right? Like they're kind of look like red blood cells in a way. But that's kind of how they'll describe it, is like you see these disc-shaped organisms. I don't know if they want to say yeast, but yeast, fungi, same thing. So that's how you know it's PJP. Okay. All right, and then the last kind of organism I'm talking about today is your Cryptococcus neoformans. So Cryptococcus neoformans is an encapsulated yeast, so it does have a capsule. This is found in soil as well as pigeon droppings. Now, normally, I think they know that people know that crypto's in pigeons, so they don't really talk about that anymore. They'll mention it with like soil. Okay, but the main takeaway, it doesn't really matter. It's got to be an immunocompromised person. So it can say like, yeah, this immunocompromised person was like walking around outside in like the dirt. You can think about crypto. Okay, it can actually make its way to the meninges if you're immunocompromised. So you basically like inhale this in, and then it can go up to the brain, specifically the meninges, if you're immunocompromised. And then they cause soap bubble lesions in the brain. I don't have a picture of what the soap bubble lesions look like. This term is used like a lot in medicine, like some of the like the MSK cancers, they cause like soap bubble lesions as well. But it's kind of like if you're looking at the brain, it just kind of looks like little bubbles, like they're, but very like light, thin, like a little bubble. Like it's very like, this looks dark, like it's very like gentle, and they just look like bubbles. I don't know, but that's kind of what it looks like. But use the whole vignette to help you diagnose it. And then lastly, they're identified via India ink staining. So that's another thing you want to look for is they'll talk about India ink. So this is India ink. And basically what India ink does is it doesn't stain the capsule, right? So you can see here's the organism. So this is Cryptococcus neoformans. Look at that capsule. It's huge around it. So that's how you can tell with India ink staining that you have Cryptococcus neoformans. All right. Give me 1 second, guys. I'm gonna pause. All right, hi guys, I'm back. Apologies. All right, so next we're going to talk about if the patient has decreased B cells. So remember with B cells, you need B cells to get rid of bacteria, especially your encapsulated bacteria, because you need as much help as possible. So I know we talked about capsules evade opsonization, but you still need as much help as possible to get rid of the capsules. So the antibodies that the B cells will make they'll still be better than if we don't have antibodies around to tag the capsule. Now, like I said, a lot of the times the capsule can help evade opsonization, but a lot of it, especially if you don't make B cells, then you definitely evade opsonization, right? But at least if you have some B cells making some antibodies, eventually the antibodies are going to be able to recognize this capsule. And then, especially if you're vaccinated, right? Something like strep pneumo, and then you can tag it and then get rid of it. So it's kind of like a double-edged sword. It's kind of like these capsules can somewhat evade opsonization, but the only way to get rid of like a bacteria with this capsule is to opsonize it. So you need to make antibodies against the capsule. Okay, so the encapsulated bacteria that are usually at fault are going to be your strep pneumo, your H flu, specifically type B, Neisseria meningitidis, Pseudomonas aeruginosa, E. coli, Salmonella, Group B strep, so like Strep agalactiae, and then Klebsiella pneumonia. These are going to be your encapsulated bacteria that will thrive if you don't have B cells to make antibodies to act as opsonins. If a patient does not have granulocytes, this is where you can see thriving of certain bacteria and certain fungi. So the bacteria that will thrive if you don't have granulocytes are Staph, Burkholderia cepacia, Pseudomonas, Nocardia, Serratia. What does this sound like, guys? This kind of sounds like if you have chronic granulomatous disease, right? So remember those 5 organisms you need to memorize for chronic granulomatous disease, which is a type of immunodeficiency. It's because you really need that respiratory burst that neutrophils have to get rid of those bacteria. Okay, so that's what you'll see. With fungi, you need granulocytes to clear out Aspergillus. And then lastly, I want to mention systemic candida. Okay, so remember I talked about T cells with local candida infections. If you have systemic candida, so let's say a good example of local candida again is like the mouth thing. So like you have oral candidiasis. That could be like, let's say they don't talk about HIV AIDS, it's not down in the esophagus, it's just like local here, local in the mouth. They don't talk about any sort of immunocompromised state. But then they talk about how maybe they're missing what cell is missing, but they have this local infection. It's a T cell deficiency if it's local. If candida becomes systemic, and that's why I wanted to highlight it here, that is usually pointing at a granulocyte deficiency. Okay. It sounds kind of backwards because you think like T cells would really help keep candida. You know, T cells are really strong, they're specific. Granulocytes are non-specific, they're innate immunity, but for whatever, I think that's why they like to ask about it. This was actually on my boards, it was on my step. Everyone wants to say, because of no T cells, but if you get systemic candida infections, that's going to be a granulocyte deficiency. If you have local candida, or if you have chronic mucocutaneous candidiasis, those are your T cell deficiencies. Okay? Cool. All right. Cancer stuff relevant to immuno. So we'll talk about tumor-specific antigens versus tumor-associated antigens. So your tumor-specific antigens are found only on tumor cells. So they're specific for the tumor cell, right? Specific for tumors. These are mutations that lead to the development of new antigens on the cancer. So these are called neoantigens. Neo here just means new. A tumor-associated antigen is still expressed. It's something that's still expressed, an antigen that's still expressed in our normal cells, but for whatever reason, they're expressed in higher amounts on the tumor cells. These ones are much harder for the immune system to mount a response against because our normal cells have these antigens. So a really good example of this is like if you have a type of B cell lymphoma that has a really high level of like CD20 or something like that, CD20, CD21. Normal B cells have CD20, CD21, CD19, all of those normal ones have it. It's just the B cell lymphoma has tons of CD19, 20, 21, whatever on its surface. But these are still harder because they're like, it's nothing new to the immune system. It doesn't recognize it as foreign. It's just like, this is supposed to be here. So I don't really know. This is where like a lot of the chemos kind of come into play. So kind of, we talked about this, so tumor specific and examples like alpha fetoprotein expression in germ cell tumors and hepatocellular carcinomas. So it's like if you have AFP, alpha fetoprotein, which should only really be made by like the fetal, like when you're pregnant and you have like a fetal like spinal cord that's being developed, like the fetal system is being developed, that's when you have AFP. You shouldn't have AFP in like hepatocellular carcinoma, like on the liver cells. So that's a tumor-specific antigen specific for hepatocellular carcinoma, for example. This one is saying like tumor associated, so like a MAGE, so melanoma associated antigen is expressed in the testes along with malignant melanoma. So I guess that's not really a good example. The CD21 I think is much better. It's kind of like it's already there on your normal cells, but it's there in like way higher amounts on the cancerous cell. So how do tumors evade our immune systems? Let's talk about it. So three things that tumors can do, and we'll talk about all three of these, is that they can cleave MIC from the surface. We'll talk about MIC. They can downregulate MHC1, and then they can lead to tolerization of the immune system. So this is MIC. So I wanted to show you in this image what MIC does. So here's like, let's say this is a target. Let's say this is a cancer cell. And remember your NK cells. NK cells are innate immune cells, but they're kind of like the innate T cells of like the innate immune system, right? So they're kind of patrolling. They're looking for MHC class 1. They're looking for that. They're looking for all sorts of things to try and keep everything at bay. But MIC is, so again, let's say this is a tumor cell. Tumor cells can upregulate MICs. So it's like MIC-A, MIC-B. It can upregulate on its surface. Wait, hold on. I'm sorry. I'm so sorry. I was like, that doesn't sound right. This is not a tumor cell. This is just a regular normal cell. This is a regular normal cell. And let's just say this cell becomes infected by something, or something happens to this cell where it's like, oh no, like I'm in danger. I need to be destroyed. Like I can cause some harm to the body. So this target cell will upregulate MIC-A and MIC-B. It will alert to like an NK cell via this NKG2D receptor. You don't have to know that. I would know MIC, but I don't think you need to know that personally. When it upregulates this and then the NK cell can bind to it, it's like, oh, this cell's in danger. This cell needs to be targeted. Another cell that can recognize the MICs are your delta gamma or your gamma delta T cells. And when this is upregulated, your NK cell, your gamma delta T cells can destroy it. Okay. So what cancer cells can do is they can actually cleave, they can get rid of MIC. So like I said, by cleaving MIC and getting rid of it, they can evade your NK cells and your gamma delta T cells. So here's like a tumor cell. And remember, tumor cells sometimes is just your normal cell that just got turned bad, basically, right? And now it's becoming cancerous. So the cell itself can upregulate MIC to be like, hey, I'm not great. Like, can you destroy me kind of thing? So here's your NK cell with the NKG2D receptor. Here's your gamma delta T cell that can recognize it. And then we destroy the cells because MIC was upregulated. Well, what if we have a tumor that wants to evade NK cells and gamma delta T cells? So what it can do is it can actually cleave off, little scissors, it can cleave off MICs and then it can proliferate and then it can grow and grow and grow. And then it's not killed by your NK cells and your gamma delta T cells. So that's one mechanism. Another mechanism is your downregulation of MHC class 1. This is like the main thing that cancer cells like to do. So they will downregulate MHC1. This helps evade your CD8 positive T cells. This is actually what NK cells are looking for, right? So remember, NK cells are basically natural killer cells. These are so important in keeping cancer like to not grow, because your NK cells are specifically looking for cells that don't have MHC class 1. They're like, oh, this might be cancerous, I got to kill it. But let's say it gets past the innate immune system. Now it's kind of, trying to go up against the adaptive immune system, notably your CD8 positive T cells. It can actually downregulate its MHC class 1, and then it can hide from your CD8 positive T cells. So we look at this image. Here is a cancer cell that is high MHC class 1. Here's your cytotoxic T cell with CD8. It recognizes it, it destroys it. Let's say this one has moderate MHC class 1. It'll recognize it, but this one's not killed first, but it's going to be killed later. But it'll be seen. Now, if you have low MHC class 1 on its surface, this can potentially escape from the cytotoxic T cells that are going around patrolling. Okay, so again, in theory, this is what your NK cells should be picking up on, but it can still, maybe they cut off that MIC as well, so they hide from the NK cells. And then the last thing that cancer cells like to do is they like to tolerize the immune response. So tolerization of the immune response basically means they're recruiting Tregs, so your regulatory T cells, to secrete IL-10 and TGF-beta. And then they're basically, this is like called like a tumor microenvironment. That's kind of like what they're doing here is like the tumor can activate T regulatory cells. So if we look here, here's your melanoma T cell. I'm sorry, your melanoma cancer cell. It's activating, positive sign, it's activating your Tregs. So we're activating Tregs to secrete IL-10 and TGF-beta. IL-10 and TGF-beta are going to basically calm down the rest of the immune system. So like these are a bunch of like not regulatory, like regular T cells. So nope. Oh my God, I'm having a moment. T cells. So like your CD4, CD8 T cells, it's kind of like regulating them. It's kind of like keeping them down. So Tregs will secrete IL-10, TGF-beta, good to know these, which calm down the immune system. So now we don't really have T cells to go and attack the cancer cell. So this is like kind of like, it's like this whole picture is showing like a tumor microenvironment. These are all the things that tumor cells can do to kind of make itself live in like a nice little bubble, hiding from the immune system, which I didn't talk about all of these. But one of the main thing that it does is this idea of tolerization. So it's tolerizing. And then one of the main ways is that it acts on your regulatory T cells to upregulate IL-10 and TGF-beta to downregulate the immune response to the tumor cell. Okay, so it's kind of what this picture is showing: tumor-induced suppression of the immune response. Here's your tumor cell in the middle, and then it's going to activate a Treg to secrete TGF-beta IL-10, which will basically shut down your T helper cells as well as your cytotoxic T cells. Okay, and then from here, how can we talk about how can we then target cancer cells then if they have all these ways of evading us? So this slide is from the innate versus adaptive lecture. So I want to talk about antibody-dependent cellular cytotoxicity. So this is where scientists can hijack this idea of antibody-dependent cellular cytotoxicity for monoclonal antibody use. So if we review this very quickly, remember NK cells have your CD16, which is it's an IgG FC receptor, so FC gamma. So it has CD16 on its surface, which recognizes the FC receptor of an IgG antibody. So let's say antibodies will bind the surface. Antibodies will bind antigens on the surface of target cells. So this is like a target cell, here's an antibody binding it. Well, NK cells have this CD16 on its surface, which recognize the FC portion of an IgG antibody. So that's what it's recognizing here. And then now it's able to release porphyrin and granzyme to kill whatever that target cell is. So this is, if we break down the name, antibody dependent, so we need antibodies, cellular cytotoxicity, which is kind of like, it's kind of like a CD8 positive T cell response, right? Like it's kind of like destroying the target cell, but it needs an antibody to do so. That's antibody dependent cellular cytotoxicity. So basically what can happen is scientists kind of hijack this idea, like they like this idea and they're like, wait, can't we just do this for like tumor cells? Can't we do this? So this is kind of what they do. So monoclonal antibodies, which we'll talk about because that is also on the study guide, the syllabus, I will say. Monoclonal antibodies are abbreviated MABs, so M for monoclonal and then AB for antibody. These are man-made IgG antibodies with FAB regions, usually specific for tumor-specific antigens, not always, but usually they're specific for tumor-specific. Hopefully that makes sense because we want to target cells that have unique antigens, or like tumor cells that have unique antigens, so like tumor-specific antigens. So let's say, I forgot if I've used this before in a previous lecture, but let's say this is a tumor cell and it has an antigen on it. We'll call it the CP antigen. So this can either be tumor specific or tumor associated, but it looks like this. It's on the surface of the tumor cell. Scientists can basically create a monoclonal antibody in a lab that is specific for this tumor cell. So this monoclonal antibody will have an FAB portion specific for the CP antigen and then a normal IgG FC portion. Okay. So then you'll infuse the patient with this monoclonal antibody, and then hopefully, look here, the FAB portion will recognize this tumor-specific antigen or tumor-associated antigen, and it'll bind it up. But that's not all, right? Because these are IgG. So here's an IgG antibody with its FC portion just sticking right out for the rest of the immune system to see. So you can get ADCC. So here's an NK cell, here's its here's its CD16 on its surface. It can bind to it, and then it can release porphyrin and granzyme. So you get basically cellular cytotoxicity. You get antibody-dependent cellular cytotoxicity. So this is just an example of how monoclonal antibodies can help kill tumor cells. So there's a lot of things that it can do. It can activate complement, which we've talked about. We didn't talk about checkpoint inhibitors yet, but it can do that. We'll talk about CAR T cells in a little bit. You can conjugate it with a drug, so you can actually use monoclonal antibodies to deliver a toxic drug to the tumor cell. But what we just talked about is kind of like you just have a monoclonal antibody bind to specific antigen or an associated antigen with the tumor, and then your NK cells just do what NK cells do, and they look for an open FC portion and then help kill that tumor cell. Here's another picture of it. People, for some reason, tend to get antibody-dependent cellular cytotoxicity confused, but all it really is your NK cell is using an antibody to help kill a target. So if an antibody is already bound to a tumor cell for some reason, so a tumor-specific, tumor-associated, the NK cell can just use its CD16 receptor. So it's going to bind to the FC, it's going to recognize that FC gamma portion, and then it can help kill it. CAR T cells. So CAR T cells, CAR, it's really cool. It's one of my favorite things ever. So CAR stands for chimeric antigen receptor T cell therapy. This is basically the same idea as a monoclonal antibody, but now we're using T cells instead of antibodies. So scientists will genetically engineer T cell receptors, basically, to be able to bind specific antigens on tumor cells. So it's kind of like a mix of like a monoclonal antibody, but now it's not just an antibody. Imagine you're like tacking that onto a T cell, like a legitimate T cell. And then right here, it's kind of like, but doesn't the body already make T cells specific against the tumor? Like, why are we doing this? Why are we doing all this? Doesn't the T cell already do this? But what if the tumor cell is evading the immune system? Or what if the tumor cell is expressing tumor-associated antigens? Like, let's say you have a B cell tumor and it puts tons of CD21 on its surface. Your T cells aren't going to they're not going to recognize CD21 because they're like, this isn't foreign. All of our B cells have CD21 on the surface. So the T cell is going to be like, I'm not going to go attack my own B cell. I'm not going to do that. So that's what CAR T cell therapy is really good for. It's like if you have a tumor-associated antigen that your immune system normally is not going to mount an immune response against. Not saying it never does, but like normally it doesn't, much less than a tumor-specific antigen compared to a tumor-associated antigen. Or what if it is a tumor-specific antigen, but it is evading the immune system somehow? Then CAR T cells are like really, really helpful. So I know this seems like very molecular biology-y, but this is very much like, do you understand what you need for a T cell receptor? And they like to ask like that understanding of T cell receptors in the creation of a CAR, so a chimeric antigen receptor. So I want to take you through this. So to make a CAR, so to make a classic chimeric antigen receptor, you need the SCFV region. I forget what this stands for. It's like something variable fragment, short chain variable something like that. Doesn't matter. This is going to be like what like the T cell receptor, like not FAB portion is, but the part that recognizes the antigen is going to be. So that's here. You have it's made up of a heavy chain region and a light chain region. Okay. Then you have, it spans the cytoplasm, or whatever of the cell. It's going to span the cytoplasm of like the T cell. And then you have your cytoplasmic tail. So you have a CD28 molecule. This is your co-stimulatory molecule. Normally it's not attached to the T cell receptor, right? Normally it's by itself off here, off to the side, but you have that. And then you have a zeta chain. So zeta chain is essentially CD3. So if we look at a classic CAR, we have the portion that's going to recognize whatever antigen we want it to recognize. So this is made up of a heavy chain and a light chain. It's called the SCFV. You have your co-stimulatory molecule, which is CD28. And then you have CD3, which is your zeta chain. All attached in one. So we basically are combining all of the things that a T cell needs to be able to mount a response in one receptor. And that's what a CAR is. So if we kind of look at it like this, so this is a normal B cell, and then this is a cancerous B cell. Look at that. They look very similar. Crazy. So our B cell has a B cell receptor. It has a CD40 on its surface, and then it has CD19, which is just a marker for B cells. But look at our cancerous B cell. It has tons of CD19 on its surface. Tons of it, way more than a normal B cell does. So is CD19 a tumor-specific antigen or a tumor-associated antigen? I'm not doing this live, so I'm assuming everyone is saying this is a tumor-associated antigen because it's a normal antigen that normal B cells have. It's just upregulated a lot more in your cancerous B cells. So this is a tumor-associated antigen. So this would be a good target for a CAR T cell. So let's make an anti-CD19 CAR construct. So we need our SCFV region. So this is going to be made up of your heavy chain, your light chain. This is essentially an anti-CD19 FAB region. Like we're basically making like an antibody FAB region that's going to recognize CD19, right? Then we have our transmembrane. Then you have your CD8. This is your co-stimulatory signal. And then you have your CD3. This is your signal transduction. So this is everything you need to activate a T cell. You have your activation. You're going to have your activation. You're going to have your co-stim. And then you're going to have a way to transduce this to the center of the cell, your signal transduction, your zeta chain. So here's kind of what you do with CAR T cell therapy. There's a mechanism called adoptive transfer. So here's our CAR that we made. So you can kind of recognize it. Here's your SCFV, here's the transmembrane, and then this is going to be like the co-stim as well as the zeta chain. So what you're basically going to do is you're going to collect the patient's blood, you're going to take out the T cells, then you're going to go do a bunch of molecular biology, PhD stuff to put these CAR T cells, CAR receptors on the T cells. So we make a CAR T cell. Then we just like expand this, we multiply, we inject it into the patient's blood, and then we put it back into the patient. So that's adoptive transfer. Adoptive transfer is not specific for just CAR T cells therapies. You can do adoptive transfer for a lot of stuff. I've actually seen, like when I was getting my PhD, I was like hearing about adoptive transfer for like macrophages. Like you take out the macrophages, you make them better, and then you put them back in the patient. So obviously it's very expensive. And a lot of the times, one of the main things that you see with CAR T cell is you get tons of like cytokine storm with this. Because I mean, I think about it, you're targeting cells and you're destroying them all at once. Because the whole job of these T cells now is to go find that antigen and go destroy that cell. So you get like tons of you get like cytokine storm a lot more than normal with your CAR T cell therapies, but they are really, really cool. They're really smart. But how you do it, the mechanism of like basically doing CAR T cells is adoptive transfer. You take out the patient's blood, you put in you reprogram, you make the CAR T cells, and then you put it back in the same patient. That's called adoptive transfer. So here's another picture. So it's showing like adoptive transfer of your effector T cells engineered to have a chimeric antigen receptor that binds to CD19. So here's your B cell tumor with your tumor-associated antigen of CD19. So here is our CAR T cell. So our CAR T cell, look, here's its normal T cell receptor. It's just not doing anything. We made our own kind of like T cell receptor that has everything you need. So here's like the SCFE portion that's going to recognize specifically CD19. Here's your co-stimulatory signal, CD28. And then here's your zeta chain. Remember, all zeta chain is your CD3. CD3 is how you get signal transduction to the center of the T cell to go tell it to do what it needs to do. So that's happening while the T cell receptor and like another T cell receptor is binding to your MHC class 1. So it's kind of like you're making it's very interesting. It's kind of like its own little mix of B cell co-stimulatory at the same time as like letting the T cell do its normal functions. It's kind of genius. I kind of wish I thought about this. Okay, so here's pharmacology. So we're going to talk about, here's the things that were from the syllabus that I talked about. So prednisone, antihistamines, epinephrine, and then tyrosine kinase inhibitors. Monoclonal antibodies were also on the list, but we just discussed them. So prednisone. So prednisone is a glucocorticoid. So remember, glucocorticoids are types of steroids. So the mechanism of action of prednisone is it's going to block NF-kappa B. We talked about NF-kappa B in the innate lecture. This is like what a lot of my PhD work was on. It focused on NF-kappa B. So prednisone blocks NF-kappa B. This was asked on my boards as well. I actually got this question twice in 2 separate blocks, specifically on STEP. I don't know why, but it was the same question, just like block 2 and like block 5 or something like that. But it just asks the mechanism of action of prednisone. So it's going to block NF-kappa B. Remember NF-kappa B, it's like nuclear factor of kappa B cells or something. That's like, remember the full word was probably the answer choice. So don't forget that. So if you're blocking NF-kappa B, you're basically suppressing both B and T cell functions by decreasing transcriptions of many cytokines. That's the best way I can describe it. It's like if you get rid of NF-kappa B, you can't activate like any immune cells. That's why glucocorticoids are very potent immunosuppressants. If you have too much glucocorticoids, you can see a Cushing syndrome. So literally like a Cushing syndrome that can happen from like, too much ACTH, or like, what you learn about in endocrine, too much um too much stimulation of like cortisol or whatever. That Cushing's, you can see Cushing syndromes with someone that's like basically has a toxicity of glucocorticoids. So I've seen questions like that where it's like patient is started on a new medication and then they're getting, the purple striae, the buffalo hump, the central adiposity, the extremities are very thin. That's like a Cushing syndrome that's happening. And then other things to note, this will be really helpful for your third year when you're on rotations. You'll sound really smart when you're not jumping at every person that has a high white count. You don't mention it. You're like, I don't think they have an infection. I think they're just on a steroid. So if a patient's on a steroid, so a lot of patients are put on steroids, especially your COPD patients, which you see in the hospital a lot. You see a lot of COPD exacerbations on like your internal medicine rotation in the hospital. So if you have a patient that has COPD, a lot of the times and it's an exacerbation, a lot of the times you treat that with like an infused glucocorticoid. Usually it's like methylprednisolone, something like that. But you give a glucocorticoid to this patient to try and like tone down the immune system to help with the COPD, help them like get everything under control. Glucocorticoids cause demargination of white blood cells. What this means is that usually if you're on a steroid, you have an elevated white blood cell count. I think we talked about demargination of white blood cells when we talked about one of the immunodeficiencies, probably, I forget, maybe, I don't know. But all this means you're not making more white blood cells, you're just causing more to come out into the peripheral blood. That's what demargination means. So like from where they're hiding or where they're kind of stored, these white blood cells, now you're causing them to come into the peripheral blood. So if you test the blood and you're like, wow, it's much higher, like you have much higher white blood cell count. Oh my God, I think they have an infection. Oh no, they're on a steroid. This is bad. Like they have an infection. Or you can just be like, or I think that their white blood cell count is because they're on a steroid, right? So pay attention to that. Look for that in vignettes as well. If they're trying to see like, what do you think the patient is on? What medication do you think the patient is on? If they have a high white count, consider a glucocorticoid like prednisone, prednisolone, something like that, methylpred, something like that. Antihistamines. So antihistamines, we talked about this with mast cells when they degranulate. Remember, this is not a great picture. I think I talk about like most pictures that they show of mast cell degranulations are wrong because you need cross-linking of two IgG antibodies. So you need some sort of cross-linking like this. And then that cross-linking is what leads to a degranulation of your mast cell. So, but one of the things that mast cells have in there when they degranulate is going to be histamine. Antihistamines just basically abate histamines, like they just kind of block the effects of histamines. They don't block degranulation, but they block once they do degranulate, they try and like neutralize these effects of the histamines. Oh yeah, I knew I was gonna put this in here. Don't forget this. Don't get this wrong, please, because they always draw it wrong. You need cross-linking. So I draw it like this, but it doesn't matter. You need some sort of antigen to cross-link. Like you can even draw it like this if you really want. Like you just need one antigen to cross-link two IgE receptors on the surface of a mast cell. Okay? This is how you make absolutely sure that you don't just get like random degranulation all the time. Okay, but they love this. So it's the cross-linking, which causes the release of the preformed granules. One of those is histamine, and then you get that degranulation. That's called degranulation, and then you get the symptoms of allergy. So what I'm experiencing right now, the scratchy throat, the stuffy nose, things like that, because I was outside earlier and pollen's terrible, and I'm very allergic to pollen. So my mast cells, my IgE antibodies specific for pollen, is being cross-linked by pollen, and I'm getting release of mast cell degranulation with histamine. It just reminded me I should probably take my allergy medicine, which I will do after this. Okay. So mast cell activation and granulocyte release. So here are all the things that you can see. So this, again, this is what I'm experiencing right now. So the eyes, the nasal passages, and the airways. What histamine does is it can cause decreased diameter, increased mucus secretion. So you get congestion, you get blockage of the airways. I don't wheeze, luckily. This is more of like an asthma presentation. You can get cough, you can get phlegm, swelling, you can get like sinusitis. The GI tract, you can actually get like diarrhea and vomiting. This is why like some people that say like, oh no, I can't have that. I have like an allergy to it. And it's like they get like diarrhea. Usually it's like a food allergy. A lot of people say that they're allergic to XYZ because it makes them have like diarrhea. Sure. And then blood vessels. Another thing that it does is it causes increased blood flow and increased permeability. I think we talked about this when we talked about like the innate immune system and how mast cells basically help with inflammation, right? You need like the blood vessels to kind of like spread apart a little bit, get that antihistamine response. But if this stays too prolonged or it happens too quickly, you can actually get hypotension. And then all of these symptoms altogether basically leads to anaphylactic shock. So this potentially leads to anaphylactic shock. Anaphylactic shock is basically all of these symptoms in overdrive, right? So this is how you get anaphylactic shock. You get mostly it's going to be this. It's because of the massive hypotension that you're getting. You're not getting blood to the organs. That by definition is called shock. So that can be what happens. Oh yes, so the point of bringing this up is for epinephrine, one of the other medications on here. So you are going to give epinephrine to patients who go into anaphylactic shock. Now, I used to get allergy shots. They really helped a lot. Like I can't go anymore, unfortunately, because of my schedule with third year, with the third year schedule. Hopefully I'm going to start back up now that I'm going to be a fourth year. But when I would go get my allergy shots, they would give me an EpiPen. Like I would have an EpiPen I'd have to bring with me for my allergy shots in case I went into anaphylactic shock, which is hilarious. So I do have my EpiPen. So you give this so I just kind of mentioned that to remind you, it's really for like an allergen. Like it's an allergen, it's a massive histamine response, which causes anaphylactic shock. This is, and I do put this note here, this is not septic shock. Septic shock, you don't give epinephrine. You can, but it's not preferred. The number one thing you give for septic shock, so this is like when you're on your ICU rotation, you're in the ICU, you give norepinephrine for septic shock. How I remember this is septic starts with an S, which is a consonant. Norepinephrine starts with an N, which is a consonant. Epinephrine starts with an E, which is a vowel. Anaphylactic starts with an A, which is a vowel. So that's kind of how I remember that. But regardless, anaphylactic shock in general is shock. So you get this profound mast cell degranulation due to some sort of allergen exposure. And this is going to cause all these sorts of symptoms. You'll see cutaneous symptoms, respiratory, cardiovascular, and GI symptoms. Something I will mention is that if they want you to think that a patient is going into anaphylactic shock, they will usually always talk about a rash. I didn't put rash. Well, I put hives, but a vignette will not be anaphylactic shock if they don't have some sort of rash. Okay, so I wanted to mention that here. Respiratory, you'll see dyspnea, you'll have cough, you'll have wheezing. Cardiovascular system, tachycardia, hypotension, because this is shock. You'll have a very narrow pulse pressure, and then GI system, you can see nausea. So epinephrine, aka your EpiPen, causes vasoconstriction, causes your increase in blood pressure. It causes bronchoconstriction, or I'm sorry, it stops the bronchoconstriction by causing it's an alpha and a beta agonist. So if we're agonizing your beta receptors in the lungs, you get bronchodilation. So that can help with the bronchoconstriction that you get with anaphylactic shock. And then it causes vasoconstriction of like the alpha receptors in the systemic circulation. So that causes vasoconstriction, which can help increase the blood pressure. Okay, so it's basically just epinephrine. So think about when you learn about epinephrine, when you're exercising, epinephrine gets released, right? So that's all you're really doing. Tyrosine kinase inhibitors. So tyrosine kinase inhibitors will end in tinib. So tinib, this ending, that's all it really means is small molecule. So like imatinib, dasatinib, nilotinib. So that's what tyrosine kinase inhibitors do. So I do want to say, like, again, I know I made this PowerPoint like however many years ago, but these are not just for cancers containing the Philadelphia chromosome. That just like I don't know if maybe a couple years ago that was the case, like it was only for cancers that contain the Philadelphia chromosome, but now you can give tyrosine kinase inhibitors for like a wide range of cancers that they know have like an upregulation of tyrosine kinase. You can give it, like I know that there's there's like a type of GI, I think it's a GI stromal tumor For GI stromal tumors, you can give, they have upregulation of tyrosine kinase. So you can actually give one of these tinibs. I forget exactly which one you give, but the one that I wanted, I guess that I wanted to talk about here at least is imatinib. So imatinib, this is called Gleevec, like the generic. So imatinib is specifically the one that you want to give for your Philadelphia chromosome cancers. And I talk about the Philadelphia chromosome in like a lot of detail. I think I'm going to talk about it here a little bit, but I go into a lot of detail for when I talk about it in my cancer lecture or session, which is in the HEMONC playlist. But anyway, so your Philadelphia chromosome is a translocation between chromosomes 9 and 22. So you can see it written as this, T922. And I'll show you a picture of what that means, this translocation. But basically what you're doing with this translocation, you're not like switching spots. Like that's kind of like when I hear translocation, I'm like, oh, like are we transferring? Like are we changing? You're making like a brand new chromosome, basically. And what it's called is like you're making a brand new chromosome, which is going to make a brand new gene. So you have ABL. ABL is a proto-oncogene. It's on chromosome 9. I talk about proto-oncogenes also in one of the oncology lectures in the HEMONC section. But regardless, ABL is a proto-oncogene. It's on chromosome 9. And then it's going to fuse with BCR on chromosome 22. So we get chromosome 9, and then which has ABL on it, chromosome 22, which has BCR on it. These guys are going to fuse. And now we made a totally new gene. It's a combination gene of, it's a fusion basically of BCR and ABL. Okay? So this is a brand new gene. BCR-ABL has upregulated tyrosine kinase activity. So this is going to cause upregulation of both myeloid and lymphoid cells, causing cancers. And this is what you get CML, so chronic myelogenous leukemia has this Philadelphia chromosome in it. Some ALLs, so acute lymphocytic leukemias, sometimes have the Philadelphia chromosome, but when you see a Philadelphia chromosome, I want you to think of CML. That one usually always has 922 translocation. So you're making basically upregulating tyrosine kinase. If you guys can remember from, cell bio back in the day, studying for the MCAT, maybe you have upregulation of tyrosine kinase. You have increased growth of those cells. Increased growth of a cell basically is setting the stage up for cancer. So that's how this cancer kind of is made. Okay, so this is kind of another version of what I tried to do with my hands, right? So here's chromosome 9 with ABL, here's chromosome 22 with BCR. And so what's going to happen is this part that contains ABL, so ABL is in this light blue, BCR is in this red. So here's a portion of chromosome 9, and then here is a portion of chromosome 22. So these two portions are going to fuse. So, and then the other unused portions, I'll say of 22 and 9, are also going to fuse. We don't really care about that. So here's like the chromosome 9 that's new. It has like this random part of chromosome 22 on it. After ABL got taken out, BCR gets taken out. So here is your Philadelphia chromosome. So it is a fusion. That's what the red and the light blue is showing, is BCR-ABL. This basically leads to constitutive tyrosine kinase activity, which leads to constitutive cell growth. So think about cell proliferation that never shuts off. There's a cancerous cell. So there's your Philadelphia chromosome. So tyrosine kinase receptors. Okay. I'm glad I have this on here. So this is like the cell bio slide of this. So what tyrosine kinase receptors do in general is they're found throughout the entire body and they're involved with cell growth and differentiation pathways. When they get activated, so here's one tyrosine kinase molecule, right? So it's going to span it. Here's a ligand, so it's going to bind to it. When you get activation of a tyrosine kinase receptor, it dimerizes. That's like one of the key things that it does. So it dimerizes when it's activated, so it's going to go find another one. So here's one, here's the other one. So that's a dimer, 2, DI for 2, and it's going to kind of get activated by this ligand here, dimerizes, and then you get upregulation of cell growth. So like so like the different pathways get upregulated. I'm not going to go into it, but these are all various types of cell growth pathways. So what I kind of wanted to do here is like the last session was immunodeficiencies. So one of the immunodeficiencies, I probably would have like quizzed you guys on this, but actually I have it here, so maybe not. But regardless, I would have quit if this was live. So this is actually the exact opposite thing that happens with Bruton's hypogammaglobulinemia. So remember in Bruton's, it's the BTK gene that gets mutated. My goodness. So BTK stands for Bruton's tyrosine kinase. But here you have no tyrosine kinase activity. That's what happens in Bruton's. You get defective BTK, defective tyrosine kinase, specifically within a B cell. So you get no B cell maturation in the bone marrow. So you get no cell proliferation because we don't have tyrosine kinase. So the cells can't grow. That's why you get these very immature B cells in Bruton's. You don't get mature B cells because they can't grow. We don't have tyrosine kinase. And then I just love this meme. Whoever came up with this meme is hilarious. So tyrosine kinase inhibitors will block the constitutive activation. So then that constitutive cell proliferation will stop. So here's like a meme. Here's an elephant. Here's chromosome 22. Here's chromosome 9 with the penguin. And then here's BCR-ABL. And here's imatinib, which is going to be your tyrosine kinase inhibitor, right? Your BCR-ABL, specifically for the Philadelphia chromosome, which is what this is. So memes are great. Okay. Okay, I think we're approaching the end. You guys are great hanging in there. So we're going to talk about imaging, diagnostic procedures, and then, or diagnostic testing, and then some procedures. So from the objectives on the syllabus, so the nitroblue tetrazolium test, this was discussed with the chronic granulomatous disease, probably the last session. We're going to talk about bone marrow biopsy, aspiration, lymph node biopsy, and then rapid antigen test. Very briefly for all of these, okay? So for bone marrow exams, you can either do an aspirate or a biopsy. An aspirate's going to be like the liquid, like you aspirate it out. Biopsy is going to be more of like, like you cut out part of that bone marrow. Aspirates are used to show morphology. Biopsies are used to show cellularity. So a morphology of individual hematopoietic stem cells, you're trying to like take out the liquid, and then you want to look at it like under a microscope and be like, what do these cells kind of look like? What do these individual cells within this liquid look like? Usually you get bone marrow aspirates to obtain ancillary testing. Like usually getting a bone marrow aspirate, you're not just going to do it just to look at it. I mean, you can, but you can't just, you can also do it to obtain ancillary tests because you have a liquid. So you can look at cell surface markers, like CD markers, you can do special stains there, you can do cytogenetics, you have like more, you can do more things with an aspirate. A biopsy, now we're going to look at the cellularity of the bone marrow. Do we have a hypercellular bone marrow? Do we have a hypocellular bone marrow? Do we have a lot of blasts? Like what's going on in the bone marrow? And then this, yeah, so this will allow infiltration like a tumor to be recognized. So if I think that a patient has a tumor, I want to do a biopsy. That's why you normally do biopsies, because I want to see what types of cells are there. If I want to run more tests on like the patient's bone marrow, I would do like an aspirate. Or you can do both. You can also do both at the same time, which we'll talk about. So here's kind of, they'll never make you pick between an aspirate and a biopsy, but I just want you to kind of see like aspirate, you can really see like the morphology of the cells. Biopsies, you can't really see morphology. Like this, I can see, like I can zoom in. I'm like, oh yeah, that looks great. That looks like a nucleated red blood cell, so that's not good. But like, you know, like, are these blasts? Like, here's a neutrophil, probably, I don't know. There's a lymphocyte. Maybe these are blasts, who knows? Whatever, but I can tell, I can look at the actual morphology of all of these cells here from the bone marrow. Biopsy, can't really do that, but it is giving me an idea of the cellularity. Is it hypercellular? Is it hypocellular? Is there a lot of fibrosis? Like what's going on here? Okay. This is kind of what they like to ask about with bone marrow exams, especially the M1, M2 level. So where do you take bone marrow aspirates or biopsies? So number one is iliac crest. So you usually go to the iliac crest, which is what's being shown here. So I really like this picture. You can see you go to like the top of the ilium, and then you can do your aspirate and biopsy. This is any age. So that's why the iliac crest is like the number one choice as well, because you can do both an aspirate and a biopsy here. So if we kind of look here, here's like a bone marrow needle. So you stick in the needle, you kind of like grind it in. You can pull back the fluid, and then you can also take out like chunks as well. And there's your biopsy. Sternum is number two. This is going to be unsuitable for children under 15 years old. So this is usually not the answer if you have a child under 15 years old. It's also the number two site. So you always want to try to go with number one if you can. But a lot of the times it's not good to go for the sternum because you can like, especially in kids that are still growing, like you can accidentally hit the heart, all sorts of stuff. So you want to try to avoid the sternum, try to go with the iliac crest. But regardless, sternum, you can only do an aspirate only. You can't do a biopsy from the sternum, of course. Like you don't want to try and mess with the sternum. It's in a kind of a sensitive location in the body. There's a lot of major organs there. So kind of how this works is you do the aspirate first. So you insert the aspiration needle, which again, this is, so kind of confusing. I have seen this in on third year. But you kind of like jam the, so this is called a jamshidi needle. And I think I like telling you guys that because it's like a funny word. And it's like a fun trivia fact, but you kind of like drill this in. So this is kind of making sure it's like getting into like basically the bone marrow part of like the bone that you're inserting it in. Then you insert the aspirate needle. So this kind of sticks through. So if you can imagine, this is going through this bigger needle and it's going to go through it. And then you can pull up the fluid, right? So you twist it down until you get the marrow, and then you attach this syringe to basically suck out the liquid of the bone marrow, and then you can make a smear. And you can use the liquid to do other things. You can do like stains, stuff like that. Your biopsy is next. Again, it's your jamshidi needle. It's the same thing. You're going down to it, and then you're gonna put in the needle is gonna be go in through it to kind of grab like solid pieces of that bone marrow. Okay. And then, yeah, and then you just pull it out and then, yep, cool. Okay. Like I said, not a doctor, but that's the best way I can explain a bone marrow biopsy and aspirate. Lymph node biopsy. So this one is good. So for lymph node biopsies, kind of like your $1 million word for just kind of like a lymph node biopsy is a sentinel lymph node. So let's say, I think this picture is really good. So let's say you have a tumor cell here. You have this tumor cell, breast cancer. So here's the breast tumor. You inject it with like a blue dye, some sort of blue dye. I think there's a name for it. I totally forget it right now, but you do inject it with like a blue dye. And then in theory, what a sentinel lymph node is it's gonna, remember we talked about sentinel cells back in one of the like the probably the innate immune system lecture. A sentinel cell, it's kind of like the first ones on the scene. They're kind of like going around, seeing if everything's good. A sentinel lymph node is going to be the first lymph nodes that are going to technically drain wherever this tumor is. So this is why it's good to have a good idea of like lymph node anatomy, because you're like, okay, if the tumor's here in this upper outer quadrant, I think the sentinel lymph nodes are going to be the first ones that are going to drain it. That's where, and you're going to probe until you get the lymph nodes that have this blue dye in it. Because if you think about it, okay, I should have started with this. These sentinel lymph nodes are in theory are going to be, if this cancer spread, these sentinel lymph nodes are going to be the first ones in theory to have gotten the metastasized cells. So if you dissect the sentinel lymph nodes and you're like, oh, there's no cancer in here, great. Then that means that the tumor did not spread yet. Because if it's not in the first lymph nodes that would have drained where the tumor is, then it's not going to be in ones later down. And sometimes the question goes like, well, why wouldn't you just dissect all of the lymph nodes if you're not sure, instead of doing like this extra work? This dissecting all of the lymph nodes, sometimes that has to be done. It's sometimes you do have, like, let's say the sentinel lymph nodes are positive for like metastasized tumor, essentially, like you have breast cancer in those lymph nodes, then yeah, you do have to dissect. That's like called like you do like a radical lymph node dissection. And you take out all of it. But if you can avoid it, because this greatly increases morbidity. So like if you think about morbidity, morbidity is like things that you do to the patient that like makes their quality of life worse. So like I guess that's like a quick way to describe morbidity, but it's kind of like if you're dissecting all of these lymph nodes out, patient's gonna get like tons of like lymphedema, like lots of lymphedema, like just tons of swelling in like the extremity that you just took out all of the lymph nodes from. So that's going to increase patients' morbidity. So if you can avoid that, avoid it. So you do a sentinel lymph node biopsy first by injecting it, seeing if those sentinel lymph nodes have cancer cell when you dissect them out. So this is like you dissect them out, you look at it, you're like, oh no cancer here, you're good to go. You close them up, you don't have to dissect any other lymph nodes. Now, let's say the sentinel lymph nodes do contain cancer, then usually you just go and dissect the rest of the lymph nodes. I mean, I guess in theory you could just keep going. Like you look at where these guys drain to, you just pick it up with the probe and you just keep going like one by one, or you just dissect all of them. You just take them all out. Okay. And that's why this is like kind of how they tie in lymphatic drainage a little bit with these types of questions. Okay. So I'll read what I wrote. So sentinel lymph nodes that initially drain tumorous tissue, right? So it's like the first lymph nodes that would, in theory, receive cancerous cells if it were to metastasize. And this is why understanding lymphatic drainage is so important. Yes. Yes, in theory. So, yes. So, when I was on my surgery rotation, I did see quite a few sentinel lymph node biopsies. They did like to pimp that. So, if you guys are going on your surgery rotation, you're going to be witnessing some breast cases. That's a good pimp question is like you're looking for the sentinel lymph nodes. But in theory, I have seen it where so I know they say like, oh yeah, you should know like your lymph node anatomy. Like I know like this is the next lymph node that would drain this location. But a lot of the times they do just inject the tumor with like this dye and then they probe and see where the dye goes. And then they do it that way. But for boards, they will sometimes want you to know what these lymph nodes are. So I will say that. Okay, and then the last slide is going to be so rapid antigen tests. So I'm only going to really talk about direct ELISAs. ELISAs, I do ELISA. I did ELISAs like every single day of my life during my PhD. I do like ELISAs. They're really good. So what ELISAs basically are ELISA stands for enzyme-linked immunosorbent assay. Basically, it's exactly kind of what it says. It's so immuno is in the name, right? So that usually means for like these diagnostic tests, you have some sort of antibody. So you have an antibody and it's enzyme linked. So we basically have like this antibody. I'll draw it correctly. Here's an antibody, and then it's linked to some sort of enzyme, something. Let's say it's like something like this. And then a lot of the times with ELISAs, what you're going to do is when it's this, basically it's like for ELISAs, you want to put this on a potential antigen that may or may not be there. So if the antigen's there, it's going to bind to it. This antibody you're adding is going to bind to this antigen. Let's say we're looking at cancer tissue and we want to see if there's a specific tumor specific antigen, or let's say we gave a drug to the tissue, like to the like not the patient, like the mouse or whatever, and then we want to see if the drug upregulated or downregulated whatever antigen we're interested in. So this is going to be what's on the plate basically that we're looking for. We are going to add our enzyme. So this is we are going to add our antibody, which recognizes this antigen. Now this might be here, this might not be here. We don't know. We don't know until the end. That's so fun about lab work, right? But anyway, let's say it is there. Your antibody is linked to an enzyme, so it's enzyme linked. So this is your enzyme. Oh, different color green. It's okay. So here's an enzyme that's linked to the antibody. And then after we do all the steps to get the antibody on this antigen, if it's, let's say it's there, then we add a substrate of some sort. Usually it's something that changes color. So we add like, I don't know, I'll just make it simple. I should have just done purple. We're gonna add a purple color, right? And then if this is here, this is bound, everything's good, this enzyme will basically break the purple down to like, let's say, I don't know, blue. Okay? And then this is how we know the presence of this blue color is how we know that this antigen was here. And what's cool about ELISAs is that they can be quantitative. So you can actually like if this is like a lot of blue, you can say, oh, there must have been a lot of antigen. If this is only like a little blue, then you're like, oh, this maybe didn't have as much antigen. So you can kind of quantify. That's why people like ELISAs in the lab. Hopefully that really quick way of explaining ELISAs makes sense. But let's say there is an antigen at all, or it's very, very low, this signal will be extremely low, or maybe there is no signal. This enzyme will really only work in the presence of antigen, but it is dependent on how many of that antigen is present in your sample. Okay? Cool. So this can detect presence of antigen or antibody. So blood typing. Yeah, so this is how blood typing works as well. So blood type, maybe not with the enzyme, but this is the idea of like how blood typing works. So the detection involves an antibody linked to an enzyme. So we talked about that. So let's use the actual picture, not just me. So the antibody linked to an enzyme. And then the sample containing the antigen of interest binds to the antibody. So here is your antigen of interest in orange. So here's our antibody that we're adding, and it's going to recognize our antigen of interest. And then you add a substrate that will activate the enzyme if bound. So a lot of the times, like I said, the substrate is usually something that you can see. So I did a chromogen. Chromogen means it's like a color change. So if I add a color, this enzyme will break it down to another color. A main one that's used a lot of the times with ELISAs is like a fluorescent signal. It's called like horseradish peroxidase. So this substrate, again, if it's present, if it's bound, if everything's there, you add it, you can also look for like a fluorescent signal. So you can use like a fluorescent like camera essentially and look for it that way. And then you can quantify it that way. Okay. So, but the point of this is if you have the presence of the antigen is there, it's directly proportional to the signal that you get at the end of the test. Cool? Cool. All right. We're doing pretty good. I think when I did this the first time, it took 3 hours. So hopefully we'll get, actually, I know we'll get all these questions done because no one's going to be answering them. So what I want you guys to do, since this is going to be pre-recorded when you're watching it, is when you have the question, just pause it because I'm going to start talking about it right away. All right? Okay. So pause. So which of the following is the most likely cause of this patient's condition? So we have a 16-year-old girl brought to the ED because of fever, vomiting, rash, worsening confusion since this morning. On questioning, her mother reports that her last menstrual period was 1 week ago, and she recently started using tampons. She appears lethargic and is only oriented to person. She has a fever. She's tachycardic. Whoa, look at that blood pressure. So I say this in like future PowerPoints, but if your blood pressure is like, if your systolic blood pressure is less than 90, this is bad. This is hemodynamic instability. You're very unstable. Yeah, okay. So very bad. She's very, very hypotensive, very, very. Examination shows oropharyngeal hyperemia and diffuse macular erythroderma. So she's got this rash, diffuse rash everywhere. So we got basically hypotension, diffuse rash, fever, and she recently started using tampons. This is toxic shock syndrome. Yes, so this is toxic shock syndrome. So what's the cause of that? How does toxic shock syndrome toxin work? Out of these answer choices, remember you get the polyclonal T cell activation. I think this question was trying to be I think it's AMBOSS, right? So the oropharyngeal hyperemia, they're like, oh, maybe this is the SPEA or SPEC from your group A strep super antigen. But I mean, this doesn't really, I mean, given everything else in the vignette, this is toxic shock syndrome from a tampon, right? So remember, you get polyclonal T cell activation. I think all these answer choices are great. But remember, this is how toxic shock syndrome toxin works. You get non-specific T cell activation, like every single T cell in the entire body, and then you get shock from that. Cool. Okay, so pause. So which of the following is the most likely mechanism of this woman's condition? So we have a 26-year-old woman. She's evaluated for fatigue and joint pain. Fatigue and joint pain. She has bilateral pain in her knees and ankles. Her symptoms have gradually increased over the past 3 weeks. Physical exam shows a rash. Oh my goodness. Lab results show the presence of ANA and anti-double-stranded DNA antibodies. So we have a malar rash. So here's your butterfly rash, right? So it's going to be on the bilateral cheeks. It's like the nasal bridge. And remember, it spares the nasolabial folds. So you can see here, it kind of spares the nasolabial folds right here. So this is lupus, right? So this is lupus. It even tells us you have ANAs positive and anti-dsDNAs positive. We get the joint pain in the bigger joints, right? So knees and ankles. So this is lupus, not rheumatoid arthritis. So from this, it's kind of like, what is the mechanism of this woman's condition? So lupus, remember, lupus is an autoimmune disease. All autoimmune diseases, the mechanism is a loss of tolerance. So I think this was good. I think it tied in. This is kind of like a third order reasoning kind of question. You had to diagnose lupus, and then you had to understand lupus was autoimmune, and then you have to know the mechanism of autoimmune diseases. So I do pose another question here. Letter C, which immunodeficiency is this? No one's here to answer, but if you have a deficiency of your mature B cells, this is your Bruton's. Remember, we talked about this at the end. This is your BTK gene that you don't have, so you can't have growth because you don't have tyrosine kinase. And then what immunodeficiency is letter D? So what if you have defective B cell class switching? So you have B cells, but you can't class switch. So the only antibody you might have is IgM. You only might have IgM. That's hyper IgM. And I'm sure I mentioned this when we talk about it in the last session, but remember, hyper IgM, you don't need elevated IgM levels. It's not like required for diagnosis. You can have normal IgM, but the diagnosis for that is going to be you only have IgM. You don't have any other antibodies. Cool. All right. Yep. So it's saying that, this is loss of tolerance because this is an autoimmune disease. So you have self-reactive autoimmunity. Cool. All right, pause everybody. Okay, so this mutation is most likely to prevent infection with which of the following viruses? Interesting question already. So an investigator is studying the effect that mutations in different parts of the respiratory tract have on susceptibility to infection. Mutation in the gene encoding for the CD21 protein is induced in a sample of cells obtained from the nasopharyngeal epithelium. So we are basically making a mutation of CD21 protein. So if you are mutating CD21 in cells that are just located in, the body somewhere, what you are most likely to prevent infection with which virus. So if you get rid of CD21, which virus can't you be infected with? You need to be 21 to enter a bar. So this is Epstein-Barr. I do want to mention too, like this is a lot of how questions are asked on like boards, especially STEP compared to complex. They really like asking like just really like you can't like this is not something like you can study. Like you can't study like an investigator is studying the effects of like you can't study that, but it's kind of like you put everything together, right? Like CD21, but it's like just the way they ask things is so interesting. And that's why I think seeing as many questions as possible is a really good way to study. Oh, okay, but yes, so you must be 21 to enter a bar. Okay, pause. Okay. So this treatment may directly lead to tumor regression through which of the following mechanisms? So a 62-year-old woman is evaluated for passage of blood clots. So she's 62, woman, passage of blood clots in her urine. Abdominal CT scan reveals a mass in the right kidney with metastasis to the lungs. She's treated with IV infusion of IL-2. This treatment may directly lead to tumor regression through which of the following mechanisms? Oh, look at me putting like stuff from previous PowerPoints on here, huh? All right, IL-2. IL-2 is T cell growth factor. So we are, if anytime they mention that you're giving IL-2 to someone for whatever reason, you're trying to increase T cells. There's actually a couple immunosuppressant medications. I think it's like cyclosporine, maybe. I forget. But I'm pretty sure it's like cyclosporin or something within that class. They specifically try to block IL-2 transcription, translation, whatever the case may be. They're trying to block IL-2 because you don't want T cells to be activated. So IL-2 is, you can literally see it and think of T cell growth factor. It helps grow T cells. So one of the T cells that it helps grow is a CD8 positive T cell. So that's really the only way that, that's really the only mechanism of how IL-2 works is you're trying to make more T cells, basically. Cool. Yeah, so even again, some of these are from Boards and Beyond, right? So Dr. Ryan here says IL-2 is famous for its role as a general T cell activator. Like I said, it's T cell growth factor. All right, so pause. So which of the following is the strongest risk factor for this patient's findings? So we have a 32-year-old male, and he comes to the office with difficulty swallowing for several weeks. Examination of the oral pharynx shows lesions on the palate and tongue that can be easily scraped off. Here's an image of the lesion. So what's the strongest risk factor for these findings? So they can be easily scraped off, right? So if they're easily scraped off, is this oral hairy leukoplakia? Is this Epstein-Barr? No. I'm talking as if people are here. All right, so this so this is an indication of having a immunodeficiency, right? So this patient probably has HIV, so that's why they have the the Candida within the mouth. So that is your HIV, basically. Cool. Okay. Um, Oh, yes, I think I put this here because we talked about if you do an inhaled corticosteroid, this could also be, yeah, because this one was really common. So I did want you guys to cross off Epstein-Barr because that is what you get the oral hairy leukoplakia thing where you can't scrape the oral leukoplakia where you can't scrape off the white lesions in the mouth. And then you're thinking about HIV or you're thinking about inhaled glucocorticoid. So if it's they didn't say that this guy has asthma, but maybe he has asthma and he takes a daily glucocorticoid inhaler. salbutamol is not a glucocorticoid. So I think this is kind of rude of them because or there's another glucocorticoid that is similar to this. I don't want to say the name, I don't remember. But there is a inhaled glucocorticoid for asthma that sounds similar to this. So that's kind of rude of Amboss, but it's okay. But you're thinking about HIV, so decline of CD4 positive T cells, or an inhaled glucocorticoid. And I think that fluticasone, that's the one, which I guess kind of sounds familiar. But salbutamol is a beta 2 agonist, which has nothing really to do with this. But this is going to be your, this is oral thrush. All right. Pause here. So serum analysis for which of the following is the most appropriate next diagnostic test? So we have a 16-year-old girl. She comes to the clinic, 9-month history of fevers, malaise, joint soreness. Recently, she noticed her urine is occasionally light brown. So this tells me some sort of hemolysis in the urine. She also notes, or hemolysis, some sort of blood is in the urine. She also notes shortness of breath when exercising. Her temperature is, so she's a fever. Everything else looks good. Physical exam shows faint erythematosus rash over the upper cheeks and the bridge of the nose. And this is where I would say like spares the nasolabial fold. Urine microscopy identifies red blood cell casts. So I talk about this in my nephrotic lecture. But if you have red blood cell casts in your urine, this is a telltale sign that you have glomerulonephritis, which is a nephritic syndrome. So overall, she has lupus, right? So this is lupus. It tells you everything, the joint pain, the fever, now it's even talking about that she has light brown urine. So she is having some sort of like lupus nephritis here. So this is going to be the next diagnostic test here. So you're thinking ANA, because usually you need a positive ANA, or one of those more specific tests for lupus, which is the answer here, which is anti-dsDNA. Another thing, I think I mentioned this, I can't remember, but anti-dsDNA, this is a really, really good specific one for lupus when you think it's lupus nephritis, which we do think she has because she has red blood cell casts, which is a nephritic syndrome, lupus nephritis, nephritic syndrome, right? So this would be a good next one to do. I don't think he put, so this is from Boards and Beyond as well. So I don't think he put on ANA because he probably thought that'd be too confusing. You do need a positive ANA to diagnose lupus, according to a rheumatologist that I worked with this past year this last year on third year. You do need a positive ANA for a lupus diagnosis, but I think that's why this question was asking, like, what are you doing to specifically rule in lupus? Now, if one of the answer choices here said, like, let's say it said anti-Smith, I would still, which is still, one of those specific ones for lupus, I would still go with anti-dsDNA because of these kidney symptoms. Okay. Because remember, the dsDNA one is really good for like the renal symptoms of lupus. Okay. Alrighty. So what are some things that he says here? Yeah, 4 of the 11 criteria. I didn't go into this diagnostic criteria for lupus. I don't think you need to know it yet, in my opinion, for first year, second year. There are a lot of good ones. But for glomerulonephritis, it's really going to be your double-stranded DNA. Yeah, so like, yeah, and even he says it here, anti-double-stranded DNA and anti-Smith, but both are highly specific for lupus, blah, blah, blah. Oh, he doesn't even really say. Okay, fine. But anti-dsDNA is really specific for the lupus nephritis. So that one usually is more correct than anti-Smith when you see it in a vignette. Alrighty, which of the following antibodies are likely to accompany this woman's current symptoms? So let's diagnose her. So 54-year-old woman, she has eye pain. She complains of joint stiffness. So joint stiffness in her hands each morning that lasts for 1 to 2 hours and then improves during the day. Look at that morning stiffness. She has increasing difficulty with routine tasks like buttoning her shirts and tying her shoes. So using her hands, it seems. And then her vital signs are normal. Physical exams, swelling and tenderness of the MCPs and the PIPs bilaterally. She has bilateral eye erythema, but no discharge, which of the following antibodies are most likely to accompany this woman's current symptoms. So if we're going to diagnose her, she's got bilateral MCP and PIP. She's between 40 and 60 years old. She's got joint stiffness that improves after use, and her hand symptoms are the most affected. So this is rheumatoid arthritis. So rheumatoid arthritis, which of the antibodies is the one that you associate with rheumatoid arthritis? But remember, it's going to be, I won't say anymore. It's anti-citrulline. So this is your CCP one, anti-CCP. ANA, I think is annoying that they put this on here. But remember, it's kind of like we think that this really sounds like it's rheumatoid arthritis. So remember, if you get, let's say you do an ANA. So let's cross off all these other ones. Let's say you do an ANA and it's positive. You're like, cool, that doesn't tell me she has rheumatoid. She could have lupus. She could have scleroderma. She could have polymyositis. Like she could have any other like autoimmune disease. ANA is very specific, sorry, very sensitive. Which one is, they're describing rheumatoid arthritis a lot. So I think she's going to have a more specific antibody, which is anti-CCP, basically. Okay. What other things? Yes, so the eye symptoms, I didn't talk about the eye symptoms, but this woman has episcleritis. So this is erythema and pain of the episclera. So like the eye between the conjunctiva and the iris, but you can also have like pericarditis, pleuritis. I know we talked about pericarditis, pleuritis briefly with like lupus, but inflammation, right? You have this rheumatoid factor IgG antibody that's just kind of, or IgM antibody against IgG, just kind of floating around. So it can go deposit, just like with lupus, it can go deposit. They're both type 3 hypersensitivity. So you can see overlap a lot with those symptoms. That's why you want to pay attention to like which joints are affected, the age of the patient, things like that to help you kind of diagnose, because a lot of these symptoms can overlap. And then let's see, ANA are positive in 1/3 of patients with rheumatoid, but are not specific markers of this autoimmune disease. ANA is found in multiple ones, like lupus, Sjogren's, scleroderma. Okay. All right. Pause, and then administration of which of the following is the most appropriate next step in management. So what are we giving? So we have a 45-year-old woman, and she's brought to the ED, sudden onset of shortness of breath, dry cough, nausea, itchy rash. So she's got a rash, she's got shortness of breath, dry cough, nausea. 30 minutes ago, she had dinner at a local seafood restaurant. Uh-oh. Patient has a history of exercise-induced asthma. She appears uncomfortable and anxious, so she's tachycardic, she's tachypnic, and then breaths are labored, 85/60. So this is, they're telling you she's hemodynamically unstable, she's very hypotensive. Examination of the skin shows this rash. Basically, she's got patches and wheals over her trunk, back, upper arms, and thighs. Her lips appear swollen. Expiratory wheezing is heard throughout both lung fields. So let's diagnose her. This is anaphylactic shock. I keep thinking someone's going to be like, anaphylactic shock. So they're giving you all the things that you need to diagnose anaphylactic shock. They're giving you a potential trigger. So seafood, like shellfish, is a really big indicator of anaphylactic shock. Bee stings are another one. What else? Peanuts, like nuts of some sort, are another one. Yeah, allergy shots are another one, honestly. That's why you get EpiPens. But oops, I gave away the answer. That's okay. So, but basically they're describing anaphylactic shock, especially what shock they're giving her. Here's the her low blood pressure. But like I said, every anaphylactic shock question is going to have your low blood pressure, a rash of some sort. They'll always mention a rash. And then, you know, these symptoms of like, you can't breathe. So like shortness of breath or like some sort of cough, something like that. So this is anaphylactic shock. Again, really highlighting the shock part of this. And then that is why you give epinephrine. You have to give epinephrine to save this patient. Okay. Yes, and that's another good point. I didn't put the other answer choices on here, but all these other answer choices you can give this patient, like you totally can. Like you can give normal saline, bump up that blood pressure. You can give corticosteroids. You can give albuterol for that wheezing. You can give an antihistamine. Omalizumab, this is like an IgE. You wouldn't give this. This is like an anti-IgE receptor blocker. This is given for people that have like specific types of allergies and asthma. I probably wouldn't give this one, but you can give all these other ones to this patient, but you need, this is what's going to save her life, is epinephrine. Okay, so you have to give it first. It has a near immediate effect. So you need to give it right away. And then you can give all this other stuff if you really want to. But first give epinephrine. Ugh, pause. Okay, so all right, let's compared to a healthy person, which of the following changes are expected in this woman for these three things? So we have a 45-year-old woman with a history of Raynaud, is evaluated for joint pain. For the past week, she has been extremely fatigued, right? She has pain in her wrists, fingers, and knees. Her temperature, so slight temperature. She has a rash and a malar distribution over her cheeks and nose, warmth, erythema, and swelling bilaterally in the wrists and knees. Okay, compared to a healthy person, which of the following changes are expected? So what do you guys think? Do you think this is rheumatoid or do you think this is lupus? So there's quite a few overlap between rheumatoid and lupus in this question, because it's like, especially her age, her wrists and fingers are involved, right? But I would still say that this is, given that rash and that her knees seem to be affected, I would still say that this is lupus. So it doesn't really matter, even if you think that this is rheumatoid. I'll actually have to see what Dr. Ryan says the answer is, because this is also from Boards and Beyond, like what he thinks this is. I think this is lupus, but you would answer it the same way, right? So if we know that we have a type 3 hypersensitivity reaction, so we have like complement is being used up in this patient, we know C3, at the very least, we know C3 is going to be decreased, right? So this is how I tend to answer questions that have like multiple things and everyone's like gets very overwhelmed. Pick one thing that you know for sure. Like I know for sure lupus, RA, doesn't matter. Complements used. So C3 or C4 is going to be low. So anything that has increased, I know I can cross off. I don't even have to look at it. So that significantly takes it down from A through H. So that's 1, 2, 3, 4, 5, 6, 7, 8. That's 8 answer choices. Now I've at least brought it down to 1, 2, 3, 4. I've halved it, which is great. And I don't even look at B, D, E, and H. I don't even look at it because I know that it's wrong and I'm not going to get got. Okay. So now from here, so I know C3's decrease. How about these inflammatory mediators? So I know in lupus or RA, you get tons of inflammation. That's why she's so fatigued. That's why she has a fever. Like you get elevated, basically inflammatory mediators like IL-1, like TNF alpha, like IL-6. So I'm assuming both of these are going to be increased. So I'm looking for increased. So I think this is C and this is C. Okay. Okay. So he does say that this is lupus. I know. So it's kind of hard. Like you do really get like, the overlap with the age, even though you get overlap with lupus and RA, but there's always going to be something that tips it one way or the other. +2, yeah, you do get symmetrical joint pain with lupus as well, but it tends to be polyarticular, meaning it's multiple joints at the same time. RA, not saying you can't have that, but it's usually always going to be the hands, at least mentioned, at least. Okay. Cool. So these are pyrogens. This is the word I couldn't say earlier. So IL-1 and TNF alpha are pyrogens. So you get a fever and you just get tons of inflammation, cachexia, things like that. So both are going to be elevated. Alrighty. So how does the toxin responsible for symptoms cause these signs? Okay, so an elderly man with diabetes develops a blister on the heel of his foot, which becomes infected. Although nursing staff in the home where he is a resident clean and treat the wound with topical antibiotic treatment, he develops a fever and hypotension, and a desquamating rash. Desquamating rash spreads from the site of the original blister. So fever, hypotension, rash on a wound that probably was packed in by these nursing staff. They probably, again, like I said, look, it doesn't have to be nasal packings, doesn't have to be tampons, it can be wounds. I wish I would have said like how they treated the wound, but because a lot of the times you don't want to make assumptions when you're trying to answer questions, but given this triad, right, the fever, the hypotension, they literally said desquamating rash, I would think that this is a toxic shock syndrome from the wound packing. Okay, so now it's like, how does the toxin respond? So how does toxic shock syndrome toxin cause shock, essentially, fever, hypotension, and rash? So again, we're looking for a mechanism of toxic shock syndrome toxin. So that one is going to be D. So we're getting cross-linking of your MHC. Remember, that's the non-specific, like you're cross-linking the MHC class 2 to the TCR polyclonally. And then you're getting massive B cell. I'm sorry, I was looking at this answer. You're getting massive T cell activation, CD4 positive T cell activation everywhere polyclonally. Cool. All right. Last question. So which of the following is the most likely diagnosis? Alrighty. So we have a 34-year-old man with AIDS. Okay, so thinking, of those illnesses. He's got decreasing vision and seeing black spots in his right eye. He has no pain and his left eye is asymptomatic. He was treated with fungal esophagitis 6 months ago with fluconazole. He was diagnosed with Kaposi sarcoma 2 years ago. Current medications include all of these HIV meds. He's on TMP SMX, multivitamins, blah, blah, blah. blah, blah, blah. BMI is 16, which is very low. Temperature, afebrile, everything. This is good. This is good. Okay. Examination shows cervical lymphadenopathy. There are multiple violaceous plaques seen over his trunk and extremities. Fundoscopic exam shows granular yellow-white opacities around the retinal vessels and multiple areas of dot blot hemorrhages. His CD4 positive T cell count is 36. So which of the following is the most likely diagnosis? So I know we didn't talk about all of these, but basically, to sum this up, the reason they're kind of giving you like, oh, he had Kaposi, then he had fungal esophagitis, is I think that they're just adding to the story that he has AIDS. So he's been sick for quite some time. So you can assume his T cell count is quite low, even though they tell you it is. But now he's getting these symptoms of like, it seems like a retinitis, and he's got plaques seen on his skin and his extremities. But mostly it seems to be, what did he come in for? He came in for that decreasing vision. So he came in for the retinitis. So retinitis with a CD4 count less than 50, what should you be thinking of? This is CMV. So CMV, remember, it's like esophagitis, retinitis, colitis, all those itises of all those organs. But look for that CD4 count. So CMV is less than 50. Remember, toxo is less than 100. I didn't really talk about HSV and varicella, but they can happen. And then HIV retinopathy. HIV retinopathy can happen, but this is more leading towards a kind of infectious presentation. Okay. All right, I think that was it. Cool. So thank you guys for letting me, kind of pre-record this. As usual, you can absolutely email me if you have questions about this or if you have material that you would like to see. All right. All right. Have a great day, everybody.